1C3 in the context of steroid metabolism. But this was at the end of this phase 2 trial with more than 120 participants. So where do we go from here if we believe that prostaglandins are key regulators? Well, the next target, which we can really start to interrogate, are the enzymes responsible for the metabolism of PGE2. Because PGE2, in the processes it regulates, is something that we are very interested in. We know that there's an interaction with estrogen signaling, and of course estrogens are believed to be involved in many processes in the lesions, including upregulation of VEGF, which drives up angiogenesis. We and others have shown an association with expression of TRPV1, which is one of these particular molecules involved in pain processing. And in 2013, Rakila et al. Already showed that this particular subtype of prostaglandin metabolizing enzymes, PGS1, was increased in the human endometriosis lesions. Some years ago, we did a preclinical study in Edinburgh using the mouse model that Yanis Smith-Stelis described yesterday, and we showed that blocking the activity of one of the receptors that is downstream of PGE2 signaling was able to abrogate a surrogate pain response in this model. So what's the activity in this area as a target? Well, actually, there is quite a lot of activity. This is an excellent drug target. It's been around for a long time. There are both natural and synthetic products, more than 300 the last time I looked. And then if we look again at what's happening actually now, there are some hopeful signs that this may be something we can produce some results for and take forward into clinical practice. So there's two particular companies' trials at the moment. So in Japan, Nippon Shinyaku have their own compound called NS580. That's already in a late phase 2 randomized controlled trial. On the website, it quotes the target population as being 380. They're going to have 3 oral doses and a placebo twice daily over 24-week intervention. The enrollment has started, but there's no results posted yet. I've been in discussion with Gesentner, who are a small company in Sweden. They have a compound with extremely high potency and a very good results in another one of these preclinical primate models where they showed reduced lesion size, improved behavioral endpoints, and persistence of effect at the end of the treatment period. You can't test this particular drug in the rodent model. And they have already designed, with input from Andrew Horn, a phase 2 RCT. They've done a lot of pharmacodynamics to work out how much dose they need, and we're hoping that this will start this year. So the other work in the targeting of the inflammation process has been looking at IL-8. There's been lots of studies in this space, but this is one that's particularly exciting at the moment. So IL-8 is a cytokine very high in the peritoneal fluid in infertile patients with endometriosis. It's been shown to be very high in the fluid of ovarian endometriosis, and it has putative roles in progression of lesion fibrosis, a process you've already heard described as involved in endometriosis. Also importantly, it acts as a chemoattractant for neutrophils and macrophages, and both neutrophils and macrophages are believed to be cells that might be targeted in therapies for endometriosis. And in the study results shown just on the right of the slide from a paper published at the end of 2023, when they did a comparison between samples of ovarian disease and endometrium in a set of patients, IL-8, unsurprisingly, appeared to be the highest expressed, differentially expressed mRNA. Now, the paper which I'm summarizing in this one slide is a very large paper, and it was published at the end of last year. And if you're interested in this area, I think it's worth having a look at its contents. So the work was undertaken in Japan and sponsored by Chugai Pharma. Now, this is a fascinating example of an innovative technology that's been brought to bear on the problem of endometriosis. So Chugai have a very innovative antibody engineering methodology, which is called recycling antibodies. They have a whole suite of these antibodies, not just the one to IL-8. And these have very high affinity and pH-dependent bindings. So what they do is they go on and off the targets very rapidly and recycle onto the target. So it's not just a one shot. So in common with a lot of other studies in this area, they used a preclinical model. In this case, they used a cynomolgus monkey. They had some with natural disease because cynomolgus do menstruate and they do develop endometriosis naturally. But they also prepared and validated a induced endometriosis model, which showed formation of lesions. And when they treated these monkeys with their antibody, they got reduced lesion size fibrosis. I couldn't see any evidence they used behavioral endpoints, but they went on to complete a phase 1 trial, which was completed in December 2022 successfully. And currently there's a phase 2 RCT underway. It looks like it's a registered trial. It looks quite challenging. They're going to give the individuals their antibody every 4 weeks for a year. But if you look at the details, and I think this is a good point after the talks that the previous speakers gave about acceptability and how you run a clinical trial. If you look at the details, the treated group are going to have 22 hospital visits for follow-up. So I wonder how that recruitment's going to go, to be honest. But it's, again, a very interesting opportunity with this. The take-home is that these new technologies, from an engineering point of view, can be things that we might be able to harness to target things we're interested in. So then, just complementing the information that Lucy gave you earlier, I want to talk about how we arrived at an opportunity to treat metabolic dysfunction in individuals with endometriosis. And again, to emphasize what Andrew said, these studies had a very long run-in. They started with an extremely talented PhD student doing their PhD with Andrew and resulted in a series of papers which were published between 2014 and 2017. So what was found in these studies, using the patient sample set that we continually obtain in Edinburgh, all the patients coming through consented to give us samples, and we biobank them, and then we go back and interrogate them time and time again, was that we found the peritoneal fluid contained very high concentrations of lactate. And the lactate was made by the mesothelial cells which lined the peritoneal cavity and was stimulated by TGF-beta. And we'd already shown that TGF-beta was high in the peritoneal fluid, so there seemed to be a sort of perfect storm there. Now, lactate is an interesting molecule, and it promotes cell proliferation and invasion. I'm sure you can see there's a theme emerging that proliferation and invasion are both things that we believed were involved in formation of lesions. And when we looked at these mesothelial cells in more detail, we realized that what we were looking at metabolically was something that made them behaving like they were cancer cells. So again, it goes to this learning from other fields, important message. And we hypothesized that if we corrected this metabolic phenotype, we would reduce lesions and symptoms. We'd basically make the mesothelium less of a welcome act for a lesion to form, or we might make the lesion shrink. Now, I've told you finding new drugs and getting them through trials in endometriosis has a very checkered history, and lots fail at 2 or 3. So we've always been keen to find drugs that are already approved. And in this respect, we went looking for a drug to target the metabolism of lactate. The studies that were done in the lab using cells had shown that there was an increased expression and activity of a particular enzyme, PDK1. And we found this compound in the data set that was called dichloroacetate, you've heard mentioned already. And importantly, whilst there was some issues to do with safety, it had been used for many years, including in children with neuroblastoma. So we did bring to bear in this case the large amount of preclinical expertise that we have, including our animal model, which we had validated and used in many trials. And this is just a summary of a huge amount of work where we treated rodents with DCA, and we showed that we were able to reduce lactate in their peritoneum, but also importantly shrink their lesions. In this study, we didn't do any behavioral outputs, but we would do these days. And just to emphasize that this kind of data, this kind of support data, is the kind of thing we had to have in order to apply to our funders for the kind of support to run the expensive clinical trials that are really the end game that we're interested in. So now I want to switch gears slightly and think about what we might learn from the ongoing genetic studies, particularly by asking whether we can learn anything from the details and excellent work done by Nilofer and her colleagues in identifying SNPs that might alter function of genes associated with endometriosis, but then take a different view, take advantage of the large databases that are out there now, and ask where there might be comorbidities with shared areas. Now, one of the things that I showed you on the first slide was many patients complain of having GI problems. Not just pain, but there might also be problems with diarrhea or other apparent problems such as bloating. Now, interestingly, back in, seems like a long time ago now, 2021, not that long ago, the group led by Dale Nyholt had shown that genetic analysis of endometriosis and depression, which is another comorbidity with endometriosis, identified loci which had evidence of potential causal links. And they highlighted, somewhat to our surprise when reading this paper, that it might be to do with gastric mucosal abnormality. Now, following on from these kinds of work, there's been much larger studies led by Sally Mortlock in Australia, and she has worked with a large international genetics consortium team to take the information from the kind of work that Nilofer described and integrate it across different data sets. And this was one just published quite recently, in which they looked at shared genetic factors in gastrointestinal disorders and endometriosis. And the right-hand side is shown some of the genetic correlation data that I extracted from this large paper. So to orientate you, the different gastrointestinal disorders in which they're comparing endometriosis and other risk factors are shown as IBS, irritable bowel syndrome, GORD, which is a reflux, pelvic, it's ulcers, and then this is GPM is a combination of GORD and PUD, but where medication has been given. And this was one of the criteria. They called this GMP, and this seemed to be a particularly strong correlation. Interestingly, inflammatory bowel disease, as opposed to inflammatory bowel syndrome, didn't have this genetic correlation. And it's important to realize, whilst they sound the same, these are, of course, quite different conditions. So if we've got these shared risk factors with IBS, can we then use this to find a therapeutic target? So it is a very large paper, and I would commend you to read it because it's got some fantastic information in it. But just to summarize, 6 of the 12 gene risk areas shared between endometriosis and the GI disorders did link to fat and estrogen-associated traits, which again goes back to these kind of common traits that tend to come through whenever we think of female reproductive disorders. But importantly, in terms of what we're talking about today, part of this study was they used the data they got, which they analyzed in many different ways to really extract out the most interesting targets. They used it as a proof of concept as to whether they could take genetic risk areas, interrogate the open target gene platform, and say, can we learn from other disorders and find drugs that we might apply to endometriosis. Again, fitting with this theme of trying to fast track things so that we can get them into clinical practice. And for this, they the two examples they gave was the PDE4B, which is targeted by this particular drug, and they showed that this approach appeared to have worked because it was already being considered for endometriosis and for IBS. But then they found a new potential target, which was CCK-BR, for which there are two different drugs available there, already validated, have been tried in GI disorders, but have never been tested in endometriosis. So one of the take-homes is there are so many more drugs and drug trials for IBS than there are for endometriosis. Can we use this sort of information? So finally, in the final phase, I just want to talk about something that's become something of a major interest to us in Edinburgh, and that is in how our microbiome, in other words, the entire micro ecosystem that exists within our gut, might contribute to kind of pain pathways that patients with endometriosis experience. Now, on the left-hand side of the slide, I've put up a review written by John Cryan, which is one of the leading experts in this area. John is someone who has established an entirely new area of drug and interventions based on treating neurological disorders, including Parkinson's, depression, and other conditions, mood conditions, which has been shown that the manipulation of the microbiome can be a highly successful way of helping alleviate symptoms. And if we look at the many symptoms and outcomes that are influenced by this bidirectional contribution between the brain that influences your gut, partially the axis, and your gut that influences your brain by virtue of metabolites made by gut microbes, we see that irritable bowel syndrome I've just discussed, anxiety, stress, and pain are all there on the list. Now, endometriosis, how is this relevant? Well, the gut-brain axis is regulated by immunological, hormonal, and neural pathways. Well, we know hormones are involved in endometriosis, and we know immunological pathways as well. Something which I don't think I had appreciated, but which is quite important in the context of thinking about endometriosis, is there are bacteria within our gut that express enzymes that are able to deconjugate and activate estrogens and thereby contribute to this. And importantly, in addition to diet, stress, which is something often described by patients with endometriosis, as well as contraceptive hormones, which they are often prescribed, all have an impact on the composition of the microbiome. So you can see this, I think this is an area we need to take into account. We have a PhD student working on this area called Francesca Hearn-Yates. She's been very active on social media, and I'd advocate you following her Instagram feed if you're interested in this area. We started her PhD by, we were listening to the patients and they kept telling us that they were interested in diet. That's why we started the project, actually. But we thought we'd better go out and find out if what our patients were saying was representative of the rest of the community. So Frankie co-designed an online survey with our patient group, and we had it online, open for 12 weeks. We promoted it very heavily, and we got nearly 3,000 responses from all over the world, but with 75% of them being based in Europe. We haven't published this data yet, but I think it's of interest to note that most of them were suffering from pelvic pain, but then remember, this was a pain survey and promoted as such. But of those, the majority were also suffering from bloating. Notably, 3/4 of them had actually changed their diet to try and manage their symptoms. Most popular diets they were using were gluten-free and dairy-free. And strikingly, up to 45% of those using these very popular diets reported a reduction in pain. So within this selected population, who clearly were motivated to fill in this survey, they felt the interventions they'd undertaken in terms of diet or supplements had helped them. So what's the landscape out there in terms of what trials are actually being looked in this area? And actually, there are relatively few. There are some ongoing at the moment, but these are some that have reported in the past. So the low FODMAP diet is one that is where you have a sort of elimination of different foods, and it's meant to reduce inflammation. It's quite a tough diet to stick to. You've got to be very motivated. In the group here, a lot of them had IBS, and where you've had IBS and endo together, which again, as I've told you, is quite common, they did report improvements. Gluten-free also seemed to be popular. An anti-inflammatory diet, typically, which we tend to refer to as the Mediterranean diet. I'm sure this is exactly what the Turkish diet is, because it all seems terribly healthy to me. Also had a reduction in pain symptoms. And then there's these more interventionist ones where you take probiotics of different types of strains to modify your diet. Amongst the trials, a couple of those that are ongoing are looking at plant-derived compounds. The curcumoids, there's Endoflex, which has not reported any published results yet. It was a double-blind with 58 individuals. And then this other one with a supplement with 180, where endometriosis was just one of several disorders. And again, no results yet. Cannabinoids, very popular amongst our patient population, widely used. But again, we need better trials to show what the best group, what type of compound, how best to use them, what the best types of compounds there are, because there's the general cannabinoids, which are mixtures of CBD and THC, but then more, there's also some drugs that target just particular receptors, such as the CB2 receptor, which is expressed in immune cells. So here there's been several trials, including phase 2-3 RCT, and I have to say we also have received funding to run a trial using cannabinoid, which Lucy Whitaker is leading, and we'll start recruiting in the autumn once all the paperwork is done, we hope. But there's challenges here with legality in some countries, and this has held us up in getting a trial going in this area, although when I talk to colleagues in other countries, such as Israel, they're already prescribing them. So just some take-home messages. We in this audience don't need to be told this. It's a complex disorder. The challenge is really trying to address symptoms and helping patients with what matters to them most at that stage in their life. I firmly believe the new knowledge gained from studies on the samples and genetics has given us great opportunities, but we really must work much harder to fast-track drugs which have already been validated, particularly in other comorbid conditions. And I believe that evidence from other pain disorders, increasing the use of non-medical interventions, including diets, rich in fermented foods, fiber and probiotics. And I think this might be particularly useful in individuals before a diagnosis when they are suffering with pain and bloating and have not yet managed to get a definitive diagnosis, and they're motivated to try to do something themselves to manage their symptoms. And certainly some people really don't want to take what they perceive as drugs. So just want to thank you for your attention. Thank my team in Edinburgh, all of us sporting these T-shirts we particularly don't like, but it was Endometriosis Action Month. Thank our funders, and I'd particularly like to acknowledge the support of the patient group, Endo West Lothian Warriors. And thank you, and I'm happy to take any questions if there is any time, although I haven't paid too much attention to time.
Thank you, Professor Saunders. Unfortunately, we have 5 minutes already passed. So thank you very much. It was a beautiful lecture, and apparently we have lots of new potential drugs on the way, hopefully. Before moving on to panel discussion, we have one presentation, the best bedside paper, which we couldn't do it yesterday because of the flight problem, apparently. Now, I would like to announce Dr. Nuran, if I'm right, Nuran Fadallah from Bahçeşehir University, and we are very proud to announce her Bedside Paper Presentation Award. Thank you for being with us.
Thank you very much. Thank you for your introduction. I have a very slightly different presentation than what we have been seeing yesterday and today. I am not a physician. I don't have medical education, but I'm an artificial intelligence engineer and researcher. And I have personal experience with endometriosis. I was diagnosed a few years ago. And I have been working in artificial intelligence and medical diagnosis for years. And when I personally had to go through the diagnosis process of endometriosis, I had to think, like, why is artificial intelligence not used in this case? And so today I just hope to inspire you to include some of the artificial intelligence tools into your research first, and then hopefully in your clinics as well. So I'll have, my presentation is going to be quick. First, I'll talk a little bit about the use of artificial intelligence in medical diagnosis. And then we will talk about studies already found in endometriosis using artificial intelligence, studies towards biomarkers discovery, and then studies in adenomyosis. So artificial intelligence has been used very widely in medical diagnosis. First, in some physical devices, as we all know, in wearables and in other devices as well. These devices are used for managing health and also used for tracking symptoms from patients, which is a very important part that have been talked about here today. Other interactive augmented reality and virtual reality technology has been used as well in medical diagnosis, especially in education and also in showing patients and getting patients to understand what is really going on. Other more important parts of using artificial intelligence is using virtual computer systems or CAD systems for aiding the diagnosis process. Some of these are using natural language processing, some are using computer vision systems, but overall they are used to help the junior physicians reach good diagnosis, sometimes comparable to senior physicians as well. So specifically for endometriosis diagnosis, there are many studies, but not compared to any other diseases. Like, for example, even with COVID, with the first year of COVID, we had almost thousands of studies using artificial intelligence. And in other diseases as well, of course, in cancer, there are millions of studies using artificial intelligence in many fields like drug discovery, like diagnosis, other fields. However, when it comes to women's health, there aren't many studies, unfortunately, and endometriosis is one of them. So most studies use one of these three main ways of diagnosis. One is symptoms, and these include patient logged tracking systems, and others use medical history. And then with imaging, we have some studies that use MRI images, others use ultrasonography. And then with biomarkers, of course, there are some genetic studies as well as microbiome studies. So I'm going to go through some of the studies with very good results, just to show you how artificial intelligence can be helpful in these kinds of research. So for symptoms-based diagnosis, we have a study, for example, that tries to predict endometriosis using medical history. And this study has been conducted in America. They used 3 million medical histories of females, and they got an accuracy of 96% to predict if these females might have endometriosis. Another study, also in the prediction of endometriosis, used the patient-collected data of both diagnosed and undiagnosed women, and the accuracy of this system was 94%. Let me just note that the importance of such studies, these do not give a diagnosis. However, they do give a prediction, which is important because, for example, I have had my doubts that I have endometriosis for years before I actually got a diagnosis. However, I had no way of finding out if these symptoms are actually related, or am I just reading things on social media and thinking that I have it, right? And so something like that, like the second study, for example, they created an app where you can log your symptoms, and it can give you a percentage to just know, should I actually go to the doctors about this, or is it just in my head, you know? For other studies used imaging. Of course, the most common things used, imaging tools used when you're diagnosing endometriosis is ultrasound. Some of them are just external ultrasound, some of them are transvaginal. But for the first study, they only used normal ultrasound images on the pelvic area, and they used 1,501 images, and they trained an AI to diagnose ovarian endometriomas based on these images, and the results, as you see, is a 91% accuracy. With these results, they compared with some senior physicians, and the results were comparable. When they compared it with junior physicians, the AI actually outperformed them, which we can think of a study like this to be an aid or help for average hospitals to be able to help the patients. Another study, also in the segmentation of ovarian endometriosis, they used MRIs. And with this one, the DICE is the accuracy for segmentation, and it was 92% accuracy, which is, again, very high, especially that they only used MRIs from 116 patients. So you can think, if we have more data in something like this, maybe we can have automatic diagnosis of MRIs in this field, which is also very interesting because, again, in my case, I did the MRI and they couldn't be sure that it is an endometrioma. So using something like that, it might be very helpful. Other studies, actually, there's a lot of studies searching for biomarkers or using already known biomarkers to diagnose endometriosis. And I think this one can actually be very helpful in many of the research out there right now. One of the studies were trying to identify molecular markers, and with the ones that they found, they created an AI to diagnose, and the sensitivity was 88%, specificity of 84%. They used plasma samples. Another study used urine peptides, and with only 122 patients, they got a sensitivity of 90%, specificity of 92. Again, very great. Another study based on genes, they used data from 213 patients, and they got a sensitivity of 100%, specificity of 61. So this can be improved on, but again, it's very interesting. Other biomarker-based diagnostic studies, we have some blood-based mRNA diagnostic signature. They use 200 plasma samples. They have also high specificity and sensitivity. Another one, they used a pipeline to try to find some biomarkers responsible. And as you see, they, again, have accuracy of 89%. And specificity of 95%. So just these are like quickly going through some of the studies that are out there that shows us that if we give more attention to finding new biomarkers with artificial intelligence, it makes sense of huge data, and it can show us some hints on where to look further.
You got just 1 minute.
Yes.
Thank you.
Yes, last 2 slides. So finally, for adenomyosis, of course, there are even less and less studies in this field. As you can see, we only have 2 studies actually in literature. One of them uses transvaginal ultrasound images of 100 patients. And of course, the dice, this is for segmentation, is 82%, but the accuracy of the deep learning for just classification of adenomyosis is very low. But another study that uses gene expression profiles is way more interesting, as it actually has some potential biomarkers identified using these data. So as a conclusion, we know that artificial intelligence uses neural networks, and it improves our understanding of unstructured data for a range of scientific applications, as already been used everywhere. Some of them is using text mining for finding biomarkers. Others use more interesting techniques. But eventually, we are trying to pave the path for better performing models in diagnostic and predictive potential of endometriosis and adenomyosis. We know that machine learning and AI facilitates the exploration of disease associations and connections across various health conditions. And so I believe that we should be doing that also with endometriosis. And then finally, although many of these models and approaches are relatively premature in terms of reliability, of course, and accuracy, rapid discoveries of relevant biomarkers and high-performing AI models at this rate have made us closer to tackling perplexing disorder at a rate faster than even before. Thank you very much.
Thank you very much, and congratulations once again. Lots of success in your future. Now we are moving on to our panel discussion. So 5 minutes. We have 5 minutes, and afterwards we'll have discussion. There'll be hot discussion in that session, hopefully.
Biraz daha yaklaştırdım koltukları. Öyle mi olsun? Şuradan kamerası var yani. İçeride. Bunun başka bir silah kaç kişi var? 19 mu oluyor? Evet. Bu tarafa yok, ona gerek yok. Atsana bir. Onu saydım da.
Ses.
Sadece onda olacak o zaman.
Kürsüdekilerden bir tanesinde öbür baş tarafa kadar gitsek. Bu da buradan.
Sol taraf olsun, sağda yer olsun isterseniz. Şu an şu taraf olmamış ki. O zaman başka taraf olmamış. Boş ver şimdi. Masa getirmeyin. Masa kalsın. Suyun yanında gidecek.
Şunu oraya bir alsana bakayım.
Yetişir mi ki? Böyle
Biraz daha çekecek dedik.
çekil. Tek masa.
Olmaz olmaz.
Tamam getir.
Ha şey mi? Bir tane daha sehpa var mı?
Aslında şu ikini ortaya koysanız, bu da şurada kalsın.
Neyi ortaya koysun?
Masa var demiş.
Nerede var? Masa mı var orada?
Yani küçük masa. Sayfa ya.
Böyle olmaz çünkü.
Zaten benim ters çevireceğim.
Neyse boş ver ya. Boş ver uğraşma. Bir şey diyeceğim.
Şimdi sahnede mi duruyoruz? Hocam yalnız çok metabolik takılıyoruz ya. Aşırı metabolik, aşırı metabolik. Aşırı metabolik. Zengin. Evet, tebrik ederim. Geç geldin. Kusura bakma. Mükemmel yapıyorsun her şeyi.
Şu Türkçe isimlerden koyar mısınız? İlk vakadan.
Bilgisayarınız var mı?
Ha ben var mı? Buraya koyduk mu? I would like to invite all the panelists in here. Please have a seat. Sağ ol. Tamam sen bunu al istersen. Ümit karışık oturun isterseniz.
Hadi zaten. 8 vakalar. 8 vakalar.
Bunu nasıl görecekler? Burada şey yok değil mi? Nasıl görecekler?
I felt the molecule.
Let's do it like this because you have to see the screen. Maybe this one is good for you. Sorry about that. Yes.
Okay.
Sorry about that one.
Mikrofonu sizler dolaştırın.
Tamam.
Again, hello everybody. Zengin Oral. We have panel in here. Panel session. We are doing this one in Turkey, in the different states, in the different end academy meetings. Now we will do a little bit more international way. In this panel, we have Christian Becker, he's here, and Katie Vincent, she's here, Andrew Horn is here, Whitaker is here, Taner Usta is here, Ahmet Kale is here, Ümit İnceboz is here, Hakan, you are in here, you cannot escape, you are in here, Bülent Berker, present, doesn't matter. And Emre Papuccio. Okay. And I discussed 8 different cases. These are the real cases in my private clinical. And I will discuss these cases just for the clinical side. I would like to answer the questions, just your experience, your opinion, not so much about the literature. Just your opinion, yeah, because we have a lot of young doctor and scientists in here to algorithm. How do you deal these cases in your clinical? This is the case 1. She just came, she's the mother. Her daughter is 16 years old. And menstruating 4 years with dysmenorrhea, but the moderate level. her relative aunt and the grandmother had been diagnosed with endometriosis, surgical confirmed, and mother asking to me what medications we have to use not to develop endometriosis like the aunt and grandmother. Because she's a mother, she wants to prevent her daughter from the endometriosis or adenomyosis. I mean, the main issue in this, does primary prevention is useful for this kind of patients? Andrew.
So the short answer is we don't have a primary prevention for endometriosis, but I think in this case it'd be obviously helpful to explore the impact that dysmenorrhea is having on her daughter. She's off school, not socializing, those sorts of things, find out a bit more, about their general health, any other symptoms. But I think it'd be reasonable, certainly in the UK, as first line, you might start with a non-steroidal for 3 months and see if that's helpful, and possibly introduce, in the UK, we'd probably use the combined pill or a progestin in first instance.
Which one?
Which combined?
I mean the progestin or the OC for this patient, not the primary prevention for dysmenorrhea.
For this patient, I think if you want my personal opinion, I'd probably offer her a combined pill such as microgynon. That's the one that we have freely available in Edinburgh. Yeah.
The second
Yeah.
generation.
Yeah.
Not the third generation.
Yeah.
Okay.
Yeah.
But you don't give any drug for the primary prevention for this one.
No, I wouldn't personally, and I know you're not wanting to refer to the literature, but I don't think there's any evidence to suggest that we would.
Yes, it's a good question, and we do not know still the answers. But I think it's not possible to give a drug for the primary prevention, but only for pain, dysmenorrhea. I would prefer first painkillers, then OC.
First painkillers, I mean non-steroidal anti-inflammatory.
Yes, yes. So it's not possible to give a drug for the prevention, primary prevention. Unfortunately, we do not have a drug like this.
Okay, Lucy.
I would certainly agree with the two members so far, that non-steroidals, and then I would go for the combined oral contraceptive rather than the progestin. I think just because the bleeding patterns are slightly more predictable, I think as a teenager that's probably a more acceptable approach. And I would aim to use a low estrogen version of the pill rather than a 30 microgram. But I think also perhaps Katie Vincent, who I know does big adolescent gynecology, she might have additional thoughts beyond that.
And what is the cutoff age for the start the OC in your country for this kind of patients? 14, 15, 16?
So we don't have a cutoff age. It's just about considering the medical eligibility criteria. So assessing for factors such as migraine with aura, which would be a contraindication to using the combined oral contraceptive.
Thank you, Katie.
So I would completely agree that we need to treat the dysmenorrhea. I be slightly controversial at an endometriosis meeting and say, I don't care whether there's underlying pathology. If a teenager's life is being impacted by her periods, then we need to address that. Whether we do that whilst we wait for a diagnosis or without looking for a diagnosis at the time, I think it's really important that we treat her dysmenorrhea. I'd make sure that she doesn't have other menstrual symptoms as well, because we often find dysmenorrhea goes with menorrhagia, and actually that has just as much of an impact on actually attending school and doing the activities that she wants to do. And if there's menorrhagia as well, or if her periods are getting in the way of her life, then I would first line go for hormonal treatment rather than painkillers. And I would choose in discussion with the patient and her mum whether they preferred a progestin or a combined oral contraceptive pill, thinking about does she have migraines and things like that as well. And I aim for amenorrhea, so I would either go for a tailored use of a combined oral contraceptive pill, and Rigevidon is the one that we first line prescribe in our area. It's up to the patient I also know lots of them who prefer using desogestrel because they're worried about side effects from estrogens, and we can buy desogestrel over the counter now, so it feels like something that's very safe to mums as well as to the girls.
Professor Rock, do we have any sonographic evidence of endometriosis in this case?
No.
Because, okay. If we don't have this evidence, I think frequent sonographic controls are really important for me, for that girl. And the first line would be the non-steroids. Yeah. Not yet.
You don't believe it for primary prevention, right?
Correct.
Yes, I go for non-steroidal anti-inflammatory medication because we know that up to 80% will be pain will will go, and obviously we have to follow this girl up since she has 7-fold increase in terms of having endometriosis in the future, but we don't know whether it progresses or not, whether she has peritoneal disease or not, whether peritoneal disease will progress or not. We don't know anything about it, but definitely we have to follow her up, perhaps yearly with ultrasound for any sign of endometriosis. But yeah, well, if this dysmenorrhea is still there, I would go for OC. For her.
Hocam is senior.
I totally agree with Ümit.
I think there is no primary prevention, not yet, till for endometriosis. My first option is the patient is menstruating for 4 years. It means that this period is very long. So I think oral contraceptive is much more better than the non-steroid anti-inflammatory drugs. 40 years, my cutoff.
I start with the non-steroid anti-inflammatory drug, and I always like this case add a magnesium during the usage of the menstruations, and some patients can benefit the usage of the magnesium. And also I give some information about the diet consumption. During that painful period, maybe they can decrease the amount of the coffee consumption, and the other activities have to increase. They can live a bit benefit that case. You said that that lady have a moderate pain, and so this situation is not too severe. In these conditions, I have to wait 2 months. The follow-up is very important. Sometimes we start with treatment and then we can lose that patient. We always invite that case 2 months or 3 months later. Then if the treatments working very well, going on the same treatments. But if that treatments will not work, and if that conditions may very badly affect the normal life, in that conditions, I start with the OC. Why I use the OC? Because we know that when you use the progestin in that age, when they face some side effect, it is very badly affect the usage of the progestin or any other methods. And in that conditions, OC better than the progestins because she haven't have a severe pain. But if that lady have a severe pain, and that severe pain very badly affect the normal life, then I clearly explain the conditions and the side effect before starting the treatments, then start the progestin.
So at the moment, per definition, she has primary dysmenorrhea. So, from the data that was shown yesterday, non-steroidals would be, appropriate to start off with and see how it goes. If hormones are indicated, I go with Katie, but that's also because we probably work closely together. We try to do to achieve amenorrhea, but I tell her, all the different options. I mean, even though she's only 16, there are other options available. Even the coil, although probably not as a starter. But I agree with the side effects. It's always an issue. But as I said yesterday, you just have to tell the patient about what could happen, and that we may have to trial a few before we get there. I believe in evidence, and there's no evidence.
Do we have enough data, solid data, the effect of the non-steroidal anti-inflammatory in these patients? I mean, could you say just briefly, primary dysmenorrhea, dysmenorrhea-related endometriosis, and non-steroidal anti-inflammatory drugs? Your opinion.
Well, I guess I'd start by saying we don't know this is primary dysmenorrhea. Until we do a laparoscopy, we don't know whether there's endometriosis there. So we're treating this as dysmenorrhea, and in our clinical practice, particularly with the teenagers, we are treating dysmenorrhea, and I don't think we should categorize it in any more way. I think that there is some evidence for non-steroidals in dysmenorrhea, but I don't think it's not very strong evidence, and certainly by the time most patients get to see us, they've already been trying non-steroidals, particularly mefenamic acid is the one that is often prescribed in the community, and they haven't responded to that, which is why they get referred in to see gynecologists. So I guess that's why we tend to think straight away about starting hormones, because they've already been suffering for quite a long time by the time they see us.
Thank you. Koray? Any comment? Too good? Okay. Any comment, any question from the audience, especially from the young ones? You too? Any comments? No. Okay. Now we will get the second one. Okay. She is one child, and in the past spontaneous pregnancy there was no problem. I followed this patient last maybe more than 15 years. There was no problem. After that, after 2 or 3 years later, she has early menopause, and at age of 36, she has been using HRT for 8 years, and in the 44 years old, suddenly I saw her 6 months ago, there was no problem. And 6 months later, I diagnosed 5 centimeter unilateral endometrioma. And I asked her, do you have any symptom, any pain? She says, yes. And the last 3 or 4 months, I have some dyspareunia and some dysmenorrhea. What is your management, Hakan?
I would consider surgery, obviously. I mean, this patient is, even though with the menopause, with the no estrogen, endometriosis might still persist. And with a new diagnosis, obviously, I would be considering the biomarkers and also the radiologic screening of the tests. But most probably, she will be, undergoing surgery.
No medical treatment?
Not at all.
Do you do etiology for this one, or HRT for women?
HRT might be, and obviously there is no, compelling evidence, but with it in the postmenopausal period, with a newly diagnosed mass, even though the radiologic screening or the biomarkers, show us that it might be benign, but I would still, consider on the surgery side.
If she has a pain complaint during daily practice, if there is a problem and life is harder for that lady, at the end, I will make an operation and salpingo-oophorectomy, also maybe combining with hysterectomy. But at last, at the end of the story, it will be like this. However, she cannot use HRT because she has an endometrioma. But as we all know, I think, after 10 or much more than years later, because of the increased iron load, the story will be end with endometrioid type carcinoma. So, according to me and in my practice, I mostly do not allow women go with endometriosis in their menopause time. So currently, maybe we can follow the lady with painkillers, but at the end, I will make an operation. Yes.
The conservative approach, not the medical one.
Yes.
Okay. Lucy? Do you have this kind of patient?
Yes, I do. Not least because I've got an interest in menopause as well as endometriosis. So just to your comment about HRT and endometriosis, I do use HRT quite a lot in my endometriosis patients, not least either because we've medically suppressed their ovaries or following on from a pelvic clearance. And I think particularly women who are having a pelvic clearance at a young age, we, yes, might be giving them the best chance of having good control of their endometriosis symptoms and reducing their risk of ovarian cancer, but we are exposing them to all those cardiovascular and bone health consequences of an early menopause, which if you remove the ovaries on someone under the age of 45, they've got their absolute risk of death is increased by, their relative risk of death is increased by 30%, and that's predominantly from cardiovascular complications. So that's a long-winded way of saying, I do use HRT. So for this patient, I think she's got a new endometrioma and a woman who's postmenopausal. So I think first and foremost, I want tissue from this to confirm that we don't have malignant transformation here. I think you can further characterize that with a CA125 and the ultrasound screening to risk stratify. But actually, this patient's not only got an endometrioma, they've also got pain symptoms. So I do think that surgery is appropriate both for tissue diagnosis and potential and aim to try and alleviate her pain. I think we can probably guarantee that less compared to giving her absolute reassurance about the features of her ovary. I think in terms of that operation, I think if we're considering that pain has been a factor, assessing the uterus for coexisting adenomyosis, appreciating what her bleeding control has been on her HRT, but I think there is an argument for considering rather than just a unilateral salpingo-oophorectomy, but actually whether or not for this patient, actually a pelvic clearance might be more appropriate as there's a definitive treatment. It will also maximize her chance of not having recurrent pain, as well as giving tissue diagnosis. And I think once that if she chooses to proceed to a pelvic clearance, if the histology is then benign, I actually then would reoffer her HRT to manage her menopause symptoms, but also to improve her bone and cardiovascular health in the long term, after surgery, as long as the tissue is benign.
So first of all, I would question my or someone else's diagnosis of the early menopause and see whether that's really the case. So have we induced the endometrioma with our HRT, or did she have just an underlying low level of ovulation still? But assuming that she is really menopausal, I think I would probably suggest also surgery in her case. I would try to minimize the procedure, as in probably take the ovary out or take salpingo-oophorectomy unilaterally. I don't think there's a need for a hysterectomy. I would rather do the salpingo-oophorectomy, put a Mirena coil in, and use transdermal estrogen for HRT. Yeah.
And stop again HRT.
Sorry?
Stop again HRT.
I think so. I mean, assuming that there's not a lot of else endometriosis. I mean, as you know, with endometrioma, there's always a slightly higher risk of deep endometriosis as well. So there might be more to do than just the salpingo-oophorectomy.
When the patient is suffering from the pain, the answer is getting a little bit easier. In this case, that ovaries, we know that it is not working, they are not working. And so they ovaries create a problem, endometrioma, during the treatment periods. And also that patient have a pain. In that conditions, I applied the surgery, take the unilateral salpingo-oophorectomy, but at the same time, I rethink again the other side. Normally we know that there's no problem, but can we take the other side or leave only one side? I don't know. It is not easy answer. But the difficult question is, if that lady haven't had any pain and we face a 5 centimeter endometrioma during that period, it is not easy to explain that conditions, which way is better for that case. But in these conditions, yes, I start with the surgery and then apply the HRT.
First of all, the surgery, but endometrioma is a hard marker. So we must search for other areas. For example, rectum, there is a nodule or not, or for ureter, there is a nodule or bladder. So we must make a detailed examination, transvaginal and special examination, whether there is a other sites lesion or not. If there is not other site lesions, this endometrioma is typical or atypical endometrioma. If there is an atypical endometrioma, there might be ovarian cancer. I suspect whether there is an ovarian cancer or not. So I need an IOTA scoring system because these ages can be seen as borderline ovarian tumors. So I keep in mind that there might be borderline ovarian tumor in this age group of patients. So I also, before the operation, I prepare myself to perform a radical surgery like ovarian cancer. I can also meet during frozen section, but the basic surgery at the beginning of is salpingo-oophorectomy, not hysterectomy, but if there is a frozen, says suspicious about the lesion, ovarian cancer, whether they're not, or in these cases, I can forward the operation.
So I think in the first instance, if she hasn't had it already, she'd need further imaging in the form of an MRI, tumor markers. But I think, like Lucy, I would offer her the option of having a pelvic clearance with a view to restarting her HRT afterwards. Yes, that would be my preference because I think we need a tissue diagnosis here. Surgery.
Yeah, not the surgery. If she doesn't want the surgery, do you do the medical treatment for this patient first time?
I think if she really didn't want to have surgery, obviously more imaging, tumor markers, monitoring, etc. Might try stopping her HRT and seeing what impact that had in the first line.
Okay. Yes, the first option should be surgery, of course, but before the surgery, I want to ask you, 6 months ago or 1 year ago, what was the size of this endometrioma?
No, there is no endometrioma. It's interesting. I just took it, I found the pictures, and there was no endometrioma 6 months ago. Just 6 months ago, 6 months later, he just came to me with the one side endometrioma.
Yeah. Yeah, of course. If some markers like CA125 and then some ultrasonographic examinations, if there is no malignancy sign in favor of malignancy, I think unilateral salpingo-oophorectomy is the best option should be.
I'll go for surgery due to sudden appearance of endometrioma plus pain at that age, perimenopausal age, although she's already menopausal according to your information. For clearance surgery, I go for, and afterwards, if the path report is fine, then I go for HRT to that lady. Thank
you. Since it's a rapid growing suspicious adnexal mass, and secondly, there is an HRT history. Probably this is the combined therapy, not estradiol only. And I will definitely go with the unilateral salpingo-oophorectomy, but I would also discuss to removal of the contralateral fallopian tube as well. If the appearance of the ovary, yeah, just fallopian tube, not ovary and uterus.
And do you prefer after the surgery and HRT?
No, definitely not. Yes.
So I would agree with everything that everyone else has said about needing to investigate and make sure that there isn't a malignancy there, and surgery to get a tissue diagnosis would be very sensible. I guess I would be inquiring why she had an early menopause. So had she had another malignancy in her youth? Did she have some kind of very inflammatory condition like rheumatoid arthritis or inflammatory bowel disease that might alter her risks for other malignancies as well, and maybe might make us think twice about what type of hormone therapy we would use? And was she on cyclical or continuous combined HRT? But if the histology was benign, I would go in the same way as Christian. I would put Mirena in and then have a continuous low-dose estradiol for HRT.
Türkçe sorabilirsiniz lütfen, rica ediyorum, çekinmeyin.
Hello, thank you for your answers. It's Ezgi. I will ask if you detect a sacrouterine or bowel nodule in this patient, and when you proceed with the surgery, would you also excise this nodule in this patient if she is asymptomatic? Because you are going to plan an HRT probably. What's going to be your plan? Thank you.
Actually, she's asking about the deep infiltrative suspicious. I don't have any surgical experience about this. Yeah, but it's so. I will not make any comment in this situation. Just I'm going to pass with the more experienced surgeons. Yes, it's a difficult question for me.
It's a difficult one, right? He cannot handle it.
We should discuss endometrioma. No, I didn't.
If I see, I normally apply the surgery for pelvic pain and deep endometriosis. If I see some nodule on the sacrouterine ligaments, we always apply the excision of that ligaments and that lesions. So my approach is a little bit aggressive. We clean the whole pelvic area and make them a clean surface.
I would agree. I mean, if you take the endometrioma out, you are potentially planning HRT. So in my case, where I would leave the uterus behind, treat all the endometriosis, and then you feel safer to start HRT again, I think.
As a surgeon, I do perform sacrouterine nodule excision, and also if there's a intestinal nodule or rectal nodule, I also make a surgery on these sites because I don't left endometriosis tissue after the surgery. Yes, it might be. It is possible.
Any other question, comment, please?
Why don't you choose the bilateral? Because she is in the menopause for 8 years. So why don't you prefer the bilateral oophorectomy?
They answered this question. They prefer because there was no problem the other side.
Okay, prophylactic as a prophylaxis. So
maybe prophylaxis, maybe as Dr. Mokic said, maybe just prophylactic serpentine.
Yeah, I heard it.
Maybe. Any comment, any question for this?
Because just I want to ask that we are preferring bilateral oophorectomy, like 50 years old patients with only one side cyst or mass. So I want to ask this question.
Any comment for this
one? Actually, some of us have already told that the pelvic clearance, not only the excision of endometrium or taking one ovary out, some of us already told this. So I am totally in agreement with you for total excision, bilateral. I don't know whether anybody.
Thank you. So I was one of those unilateral salpingo-oophorectomy people. Well, so I'm not an oncologist, but I think there's a lot of controversy whether or not. I think I would probably discuss with her to remove maybe the other two, whether the ovary is necessary or not. I think, as we know, most of the serous carcinomas come from the fallopian tube. My approach is always do as much as you need to, but not too much. And I wouldn't take the appendix out just because she could have an appendicitis, because I'm there. So, I mean, it's a bad argument. I know cancer is a different story. Absolutely, no, get that. But I would discuss it with her, yes.
What I did this patient, I discussed patient and I offered the unilateral. And she She preferred the total hysterectomy and really total hysterectomy. And at that time, I prefer frozen because of the borderline risk. And they say in a good hospital, in a good pathologist, there is no problem. And after 1 week later, and the pathologist say, we have just focal low-grade borderline tumor. And now she is on HRT 1 year. I just changed the protocol and lower the dose. She is okay now with the new protocol. The first one, I choose the progesterone. And for the primary prevention, we have no solid data. We have just one data from the Australian, something like that, for the primary prevention by Jason Abbott. But I prefer, instead of the OC, progesterone for this patient. She's on progesterone, dydrogesterone, just one per day. And she has menstruation. Why I choose the OC instead, progesterone instead of OC? Because of the estrogen. Maybe there is a problem with the long time, as Chaplin said, for the deep endometriosis or the endometriosis, increase of incidence of endometriosis and height of endometriosis. She has on dydrogesterone treatment for the last 2 years. Thank you. Next. And this patient is a single woman, and she's 28 years old, diagnosed 6 centimeter endometrioma, and my other doctors. And she came to me for the fertility preservation. I look at the HM is 1.8 per ml, and now we have to discuss the patient for the future fertility and the fertility preservation.
So this patient is a very good candidate for fertility preservation. And the AMH is 1.8. I would classify her as suboptimal responder, I mean 1 to 2 nanogram per ml. And with 6 centimeter OMA unilateral, I would be considering, egg freezing. And for this patient, since she's single,
If her AMH level 2.2.
then I would consider not egg freezing, but if, the postponement of, obviously she wouldn't, forecast it, but if this is an issue, she might in the future, but not nowadays, she might be considering egg freezing. And for this patient, at female age 28, a good number of eggs, this is also a very relevant question. Is around 10 mature eggs to be frozen would be on the safe side for this patient for future use.
How many eggs do you need for the future fertility for this patient in this age, in this AMH?
I would consider around 10 would be a reasonable number. 10 would be a reasonable number.
Okay, thank you. No, she's just dealing with it for the future fertility. She has not the big problem. Recep Hoca?
Well, this is interesting cases. How about the other ovary?
No problem, just this one.
In the contralateral ovary has enough follicle, and this lady has heavy pain. I can consider the medical surgery, the excision stripping also.
For this patient?
Yes.
And how about
provided that having the other side is...
Other side is normal, but you prefer surgery. Before the surgery, do you recommend the fertility preservation or not?
Right, of course.
Right. Lazım.
I will not go with surgery. Since it's a young lady and the AMH level is somehow low, pretty low, not so low, but it's moderate. Yeah, it's a moderate value. So I would definitely go with the fertility preservation. Why? Because in the younger age, and this AMH provides us.
How many eggs?
If you vitrify 10x, it's going to be 25 to 30% cumulative live birth rate. But if you vitrify between 10 to 15, then it will give you nearly 50%. Then I would go with 10 more than 10 to 15. Maybe 2 cycles, I don't know. So I would definitely go with 1 or 2 cycles of oocyte vitrification, and then progesterone treatment, at least to observe whether this single-sided mass is going to decrease or not.
Ümit?
Totally agreed. Go for oocyte cryopreservation, and afterwards, after completing 10 to 12 or 15, I put her on medication as well.
After the surgery?
Yeah.
Okay.
So,
do you deal with this kind of patients in your practice? No, right?
So if I saw her, I'd assess whether she had any symptoms, and then I would send her to Christian, and she can discuss it with him, and she can come back to me to talk about the pain afterwards if needed.
Christian.
She would probably have pain after speaking to me, I would think. So I think I would agree what others have said. I would suggest, well, I would offer fertility preservation. The problem is you have to pay for it. It's private.
In this AMH level, right?
Yeah, exactly.
And how about the 2.2?
So I'm always struggling with the nanograms per milliliters because
yes.
we always would.
I mean 7 for in your yes. You have to plus, yes, 7. That means 2.5 and 15, something like that.
Yeah.
In your nomogram.
Yeah. So if it was higher, if it was 15 or so.
Yes, 15. Like that.
I would still. I mean, the endometrioma is not going to go away, right? I mean, it's good that she's asymptomatic. It sounds like. I mean, from an endometrioma perspective, you could just monitor it with ultrasound. You don't necessarily have to jump in, but if she's interested in fertility, I would at least offer it to her. But as we know, she may have to go through more than 1 cycle, and that I don't know if she's at 28, whether she has the finances to go and pay for that. Unfortunately, it's not funded.
Okay, Lucy.
So I'm rather in Katie's position that I would assess her pain symptoms, then send her to a fertility person who knows more about this than I do. But I think it is in part driven by what her symptoms are. And as you've said, she's asymptomatic. So it's then making those difficult decisions of whether or not to do preservation for the future in the UK, where it would have to be self-funded. And it is extremely expensive, and not for many people, they can't afford it.
She is asymptomatic. Would you try the medical treatment for this patient, except the fertility preservation?
I'm not sure we've got good evidence to say that if we medically suppress this will improve her fertility options in the future. And we also don't have good evidence to say this will prevent you from your endometriosis progressing to perhaps cause new symptoms in the future. I think you can discuss the pros and cons and the limitations of the evidence, and then allow her to make as informed as she can be with the paucity of evidence. But I think it's certainly in terms of the fertility component, that I would send her to those who are more experienced and more informed than I am.
Controversial. Andrew?
So I work solely in the public sector. So interestingly, I wouldn't be presented with a patient like this because she wouldn't have had an AMH level as routine. So I suppose putting myself in that position, if she presented...
Do you use the AMH as routine or not?
We use them in certain, so we would use them if someone had bilateral endometrioma, or if there was some history of infertility, but we wouldn't routinely with someone just with a single.
If this patient just come to your office, just like this without AMH, and she is asking for future fertility preservation, what is your algorithm? Do you do the AMH or antral follicle count, or just follow up?
So again, I tend to see patients with pain rather than, I'm not trying to get out of the question, but so I would involve a fertility doctor. I don't think in Edinburgh they would routinely do an AMH on someone who was with a single endometrioma. I suppose if she was really pushing to get it done, we probably would do it, but it wouldn't be part of a routine pathway. I'm looking at Lucy.
But you have the permission for the social freezing, right? You have the permission, social egg freezing.
But they'd have to pay for it.
But paid, but there is a permission from the government, right? Okay, in this country we don't. That's why. Ahmet. But for, I mean the social freezing, Hakan.
I'm sorry. The presence of endometriosis per se is an indication for
Yes,
freezing.
definitely. Ahmet.
Her AMH level is moderate. I think it is better or logical to offer fertility preservation for this patient.
For this patient.
Yes, it is logical.
Bülent?
For this patient, if she does not have really a pain, and
no.
if she not urgently want a baby, because I have written she's single, I will not touch anything, because every endometrioma, diagnosis of every endometrioma does not mean that you have to operate, you have to act something. But for the future, for example, I may add oral contraceptive for slowdown of the development of endometrioma. For the future, again, if she wants, in a way, if she wants oocyte freezing, I may apply laparoscopic sclerotherapy, and without touching ovarian reserve, I may increase the number of the eggs in the future I will obtain. So if there is no problem, AMH is normal, no pain, I will apply only OC and follow the patient.
Please.
Sorry. Were you going to say? Can I ask, has anyone or is anyone doing sclerotherapy transvaginally under ultrasound guidance, or are you, Ümit? Or?
Emre? Ümit? Just before the Taner?
When I see that case, yes, I can send that case for IVF, for fertility preservation. But if that lady don't want to go to fertility preservation, in that conditions, I start with the OCP, because this is not a small endometrioma. This is around 6 centimeters. If that endometrioma getting higher without any symptoms, maybe she can need the operations again. I try to decrease the operation probability.
Thank you. Ümit, Emre, for the question. Christian Becker. Just.
Yes, I do transvaginal sclerotherapy, but reaccumulation is so rapid. So
Are you happy with the result? Are you happy with the result?
Not completely, but it depends on the patient's situation. We have to select the proper patients for transvaginal sclerotherapy, I guess. Yes. No. I mean, when I take the fluid out, and then I can find I do it pre-IVF cycles, so it is very easy to find eggs. So I'm not always checking with AMH. I don't think that there's any point to check it. One more thing, if I may, to Bülent Berker's talk. Do you think that there's a role for egg freezing if the AMH level is already down? So is there any logic to wait AMH level goes down? So if we want to do egg freezing, we have to do it when AMH is still in somewhere, I mean, at least moderate.
Emre?
I want to make one point clear, that it's reasonable and feasible to vitrify these oocytes when the woman is younger than 35, just due to the oocyte quality and the quantity to achieve that cumulative live birth rates. That's the first point. And the second one, for the question, we use sclerotherapy, but we are not happy at all, because, you know, two major problems are just, we observe that. The first one is the infection. We already got 2 abscesses, and we opened that.
Which is the bad one.
Yes. And the second one is the procedure is not easy. You're putting in 99% ethanol over there, and we are just now weird just during the procedure. And we only do the sclerotherapy just beginning of the ovarian stimulation of the very, very big and discomfort endometriomas. Because if you push so many gonadotropins, your estradiol level goes and the cyst wall is going to be disrupted. So we only offer the sclerotherapy, aspiration and sclerotherapy, just be beginning of the ovarian stimulation to comfort the patient.
Just temporary.
Yeah.
Okay, Bülent. Defensive.
I want to add something, according to me, important. Sclerotherapy is a misunderstood name because there is no therapy. So, alcohol application, we can say. And as you have written here, it's a single woman. What I understood, she is virgin. So,
no, she's not virgin.
But do not forget that via ultrasound, endometrioma seems like endometrioma, but still it's a suspicious adnexal mass. So we have to approach this lady via laparoscopy because we do not know the exact pathology. If we will apply sclerotherapy, I think it will be the way of laparoscopy.
Thank you. Any question, any comment? Please, Dr. Sarah.
If she has bilateral endometrioma with 6 centimeters and more difficult case, if she has also bilateral kissing ovaries, what will you do in that case in terms of fertility preservation?
Preservation.
Thank
I mean
you.
the not unilateral, bilateral. Hakan sana bakarak sordu. Cevap verir misin lütfen? These are Turkish jokes. That's why my English is not enough to translate this one.
The answer is very simple. I would go ahead with egg freezing.
Again, the egg freezing.
With such an
You don't afraid for bilateral?
No need for surgery.
No need for surgery. Okay.
We should avoid surgery. Surgery, I would consider is even not to be considered at all.
Another comment?
It's about the sclerotherapy. During the laparoscopy, we apply sclerotherapy with laparoscopic way. Sometimes suction is not enough to take the chocolate fluid out with 5 millimeters. And so transvaginal way, I guess that in some conditions you have a experience about that one, but we always think that one. Last week we applied the sclerotherapy, but with the suction drainage, it is not so easy. It is very thick and very dense.
That's why they recommend the catheter instead of just the needle. Christian?
I think with bilateral, I would probably do a transvaginal scan to see whether they're accessible for egg collection. If they're high up in the sky, then I'm a bit worried about poking through bowel and causing infection. So then, I mean, I said earlier, I like evidence. What we sometimes do without evidence then is discuss with the patient whether we just drain the cyst and then stimulate, collect the eggs, so mobilize, get them down in the pelvis, not do the major operation, leave the cyst in, but just drain them, stimulate, collect, and then do the proper operation at the later stage. It's not fantastic, but something to consider.
Not the laparoscopic approach, right? Just transvaginal. Not
no, laparoscopically, but not do the full operation because we want to keep the AMH as good as possible.
Okay. Very short.
Very short. During laparoscopic sclerotherapy, if you wash with saline endometrioma, it will kill the endometrioma fluid. So after washing so continuously, you can apply the laparoscopy. You can apply the ethanol sclerotherapy during laparoscopic surgery.
Like Horasman did.
Yes.
Emre?
A little trick. If your fluid is dense, more dense the fluid, the more duration, and it's going to be an infectious state. It's an important point.
Thank you. Quick.
Can we monitor the AMH levels after 1 year from surgery?
Sorry,
if
say
so-
again, say again.
Sorry. Do you monitor AMH levels after the surgery? And if so, if the AMH levels increases, will you still keep the eggs reserves? I will curious about that. Thank you.
Any answer for this one? I will prefer the monitoring, but at least more than 6 months later. And according to the result, not increase our aim to preserve the preoperative level, not increase. Any other question?
I have a question.
Kaçta başladık? Yarım saat falan oldu herhalde.
In this case, I imagine two different patients with 6 centimeter unilateral endometrioma, and one of them we can see the chocolate cyst. Besides chocolate cyst, we can see cortex of over, and for example, we can count 4 or 5 follicle, and in the other patients, the 6 cm endometrioma may cover all of over or most of over. Is there any difference? Do you think is it important or not?
I mean, for the antral follicle count, right?
Yes.
It is a little bit questionable in my practice because sometimes you can see the other side of the ovary if she has the good response, but sometimes you cannot. But after the surgery, you can see the more follicle in there because the compression is hidden the other antral follicles behind the cyst.
But I want to say I'm talking about the same side. The other side, both of them have both patients have same antral follicle, but the same side with endometrioma. One patient has no antral follicle and has no cortex because cysts cover most of over, and the other patient, same side with endometrioma, there is a cortex of over, and it is enough, and we may count follicles.
Any comment for this question?
Antral follicle count might be misleading in patients. Antral follicle count, normally in fertility practice, AMH and antral follicle count can be used interchangeably. We also very recently published this. But in patient with OMA, antral follicle count due to this compression volume effect might be misleading. So you should be relying more on AMH rather than antral follicle count.
What I did this patient, I discussed the patient, the case 3, and I said you have the moderate AMH level. If you want, you can wait, or we can do fertility preservation. She preferred to wait. I put on OC because she has the sexual life. After 8-9 months later, again on OC, medical treatment, I look at again the AMH at the same laboratory. This time it was 1.5. 1 week later, I repeated, it was 1.6. And we decided the fertility preservation, and I canceled the OC. 2 months later, we did a fertility preservation. We get the 6 mature oocyte, and we will plan another one now for this patient. Unfortunately, we have no time, and we will discuss just one more case. Okay, let's start with let's choose this one, case 7. And 32 years old woman has been married for 3 years, desire of fertility, AMH is 1.2, spermiogram is normal, she has no pain symptoms, and in my examination, just 2 centimeter nodule is the rear area, posterior fornix, and she has no endometrioma. Let's start here. This is the last case, unfortunately.
Do we have hysterosalpingography of
It's
this?
normal.
No.
It's normal.
Right. And she has no pain, although she has
no
nodule.
Pain. She has no pain, and she has the nodule. Nodule is the true, and no endometrioma, and the other ones are normal, and the low level of AMH 1.2, and 3 years.
Well, definitely we have to talk with this couple properly. I mean, we have to spend some time. We have to tell them that they can still achieve pregnancy spontaneously. That's the chance, but the chance is low.
After 3 years.
After 3 years, the chance is low. We can explain the percentages, etc. And for this lady, I would probably offer IVF as well. Because she has low AMH level. Definitely I have to check with antral follicle count because sometimes AMH is wrong. And I'll go for IVF cycle for her, I guess. Or surgery might be an option, but still she has low AMH. I go for an IVF first.
So again, she wouldn't come to me because she would go to the fertility specialist, but I would imagine they would offer her IVF and they would probably discuss her with us in the endometriosis service, and we wouldn't offer excision of the nodule if she's asymptomatic, not in this instance.
And medical treatment, I mean, not the fertility issue. She has just came to without fertility issue. She has just a 2 centimeter nodule.
So without any symptoms?
Yeah, without any symptoms.
I wouldn't do anything. I would observe, offer her the opportunity for monitoring of the nodule, although again, there isn't evidence necessarily for doing that, but no, I wouldn't offer any treatment.
If you choose the medical treatment, would you choose the OC, progesterone, or other ones? Do you have the GnRH antagonist in your country?
We're just about to get it, so potentially. I'd probably, if she no fertility issues and she was wanting, are you saying give her treatment to prevent the nodule getting bigger, or because if she's got no symptoms, I wouldn't give her any.
She has just one.
Just the nodule and no symptoms.
We don't know for the future, but she has 2 centimeter nodule in there. We can see the photo sonography. It's clear, but no big symptoms. Just constipation sometimes, something like that. That's it.
Yeah, I wouldn't offer her any treatment.
For fertility issues, I sent this patient to the fertility clinics, but she has no any other symptoms. So pain symptoms, it means that I think it is a secretory nodule, 2 centimeter. It is an asymptomatic nodule. So just I follow up this patient and doesn't give any medication.
Just follow up.
Yes, just follow up.
Right?
If she has a chance of IVF, of course, the IVF should be the best treatment because although age is okay, she's younger, but 3 years of infertility duration is an indication for fertility treatment. And unfortunately, AMH level is very critical. So maybe, of course, she has pelvic peritoneal endometriosis, but in practice, in clinical practice, spermiogram is normal, tubals are patent. Only problem is ovarian reserve, which was decreased. So if she has economic or something capabilities, of course, IVF will be the
IVF.
I start with the previous question you asked, Andrew. We have some cases, they have a 2.5 or 3 centimeters nodule and there's no pain. We always follow up.
In this age, right?
Yeah, in this age, and one of them is 37 and there's no pain, but we clearly see the rectal or rectostigmoid endometriosis, endometriotic nodule. If they attach the posterior vaginal wall, in that condition, we see much more pain, but if it's separate, the pain is very low or no. In these conditions, I completely agree with the Professor Berker. 3 years is a very good test for that couple because 2 years without contraception and there's no fertility, and the AMH is 1.2 is not too very good reveal as ovarian reserve. In that conditions, I directly send that patients the IVF treatment.
I agree. So, I mean, what we're waiting for, so 3 years of infertility, IVF is the way forward. And from a endometriosis perspective, do no harm if she's well. You know, we can only make it worse by doing surgery. I would monitor it, but that's all I would do.
Before IVF? Before IVF or after IVF?
What do you mean, monitoring?
Yes, she wants a baby.
Yeah. Leave the nodule, monitor it afterwards. You know, who knows what happens after pregnancy as well. You know, the pregnancy hormones may.
How can she get the pregnancy? I mean, with the IVF or spontaneous?
With IVF.
With the IVF.
After 3 years, I would do.
After the IVF, do you suggest surgery or not?
If she's still
after the pregnancy and
if she's still asymptomatic, no.
Okay.
Proceed. And yes, I would very much agree that IVF is the way forward for this patient. And given that she's asymptomatic, we wouldn't specifically intervene. I think some patients would ask for, is there merit in hormonal treatment to the, once they've gone through their fertility process to prevent this getting worse? And we would have an honest discussion going, we just don't know. I mean, I would also say, so with us in the public sector, the Scottish NHS, we also wouldn't have the facility to follow up this patient. We would have to return them to patient-initiated follow-up. We tend to use a criteria of a nodule of 3 centimetres or more for annual screening, actually predominantly of the renal tract, to ensure there's no occult hydronephrosis. But at 2 centimetres and asymptomatic, we would discharge them back to primary care and then pursue the fertility through
just
the IVF separately.
Screen, right? Annual. Okay. Hakan?
Thank you. So surgery should be avoided. And with this patient, with a single attempt, with a single blastocyst transfer, either fresh or frozen, she will be looking at around 50%, 50% of live birth rate for single attempt. So, I mean, just the presence of 3 years infertility, I mean, is enough to consider IVF.
After the baby, would you recommend surgery or not?
If no symptoms, surgery should be avoided. As already
Thank you.
discussed.
Emre?
I would definitely go with the IVF treatment. I will vitrify as much as blastocyst as I can, and then go with, according to the age, the single blastocyst transfer, but in frozen cycles. Probably I will suppress 2 months by using the Dienogest or something else, and the 3rd month I will go with the frozen embryo transfer cycle.
Do you do PGD in the first cycle in this patient? PGD?
Not preferably, because the age is 32.
Hakan?
Our main indication for PGT-A is the advanced female age, which is our threshold is age 35. So I would not consider.
Not consider. The interesting thing for this patient, she has no endometrioma. Maybe she has the just superficial endometriosis. We don't know. There is no surgery. And could we say deep endometriosis has etiology for fertility problem? That's important because she has no, except the nodule, we could say this is unexplained. Just a little bit low ovarian reserve. I offered the IVF to this patient. We did IVF, not PGD, and she has the, in the first cycle, she has the pregnancy, but the problem, she needs 3 times hospital admissions because of the suppleus symptoms 3 times, and the 16 weeks and around 24 weeks, and before the labor 36, and after that 3rd one I did the cesarean section. I don't know, it's the reason of the subocclusive symptoms in these patients because of the nodule, and she's just the baby 2 months late, 2 months ago, and we will discuss with Taner to discuss the surgery or this not for this patient for the next 1 year, because We don't know this is the nodule just 2 centimeter. During the test process, we have the MRI and something like this. The same nodule is there, not growing. It is interesting. And but she was so suffered, and she said to me, why we didn't choose the surgery before the IVF? But I didn't mention surgery even before the IVF. I just said, this is in there. Hopefully we will not get any problem. We will not get any problem. Most of the patients have problem. This is just a kind of separate patient, but this is the position. Any comments? Do you have any for this patient? Because you will send to the, okay, that's one. Any comments?
Any regression of the nodular size after pregnancy?
No, just 2 centimeters in there.
If this patient manifests herself as a superior symptoms, it means that there might be a checal or ileal endometriosis. It might be missed during transvaginal examination. That's because it is very higher level, so maybe MRI is needed to verify whether there's ileal or checal endometriosis.
It was typical subocclusive symptoms, and 3 or 4 days later, it's resolved.
We have a case that admitted to our hospital as a superios, and during surgery we found ileal checal endometriosis.
Taner?
There was one
don't answer. Later.
There was one retrospective paper. It's coming from the France, and they said that if the patient had a nodule before the pregnancy, they can face 10% of superiors or ileus. How can I say that problem during the pregnancy?
We mentioned yesterday afternoon for this subject. And Turman and Horace Roman.
So normally we do not expect that the 2 centimeters nodule may resolve with that problem, but in that conditions, Ahmet, I completely agree with Ahmet, and so we have to see the other parts, especially the terminal ileum, the other parts, sigmoid regions. We are not very well on the lower. We are very well on the lower pelvis, but we have to know better the upper part of the pelvis.
Okay. Another comment, question? You are a basic scientist.
Yeah,
this is a clinical question.
No, not for the patient or doctor issue. I was just asking that do we have information about any chemical pregnancy before it happened to her? Could we detect
for this patient? No,
yeah, for 3
she has
years
no
or
pregnancy.
something?
As she
Ah,
said,
okay.
no pregnancy.
Thank you.
Any comment? Any questions? Unfortunately, time is limited and it's finished. Thank you so much for the good discussion. I learned something. Thank you so much. And we will just 10 minutes break, and after that we will have the about symposium, and the title will be oral progestin therapy in fertility area. Please join us. Thank you so much. Thank you so much. Thank you so much. Thank you. Very nice. Yes, please.
Sertaç İstanbul'da değil mi şimdi?
Peki sonra bizimki mi başlıyor? Yok hocam, sonra küçük bir kesişim daha var, sonra bizimki başlıyor. Afternoon or noon time, and this is the only atmosphere by ever. And the topic will be fertility and progestogens. And our guest speaker, young and motivated speaker, they say my man, actually Emre Papucu is our man. He is just professor in Ankara. He is certified surgeon in minimal invasive gynecological surgery. It is our honor, he is our core member of Endometriosis and Adenomyosis Society Turkey. And his research mainly reproductive medicine, endometriosis, adenomyosis, and menopause. He is dealing with the IVF procedure, either university or private sector. Please, Papucu.
Thank you, Professor. I would like to thank the Abbott company for their kind invitation to this nice symposium. I think you can hear me, so I may not use the mic. Okay. If we need, I can use that. Today I'm going to give you a lecture about the progesterone and infertility, because as we all know that the progesterones are essential biomarkers, especially in the field of assisted reproduction. what we need for the effective implantation. Implantation process is a black box. We don't know. Okay, okay. Thank you. Implantation process is a black box because, you know, we don't know so much about the biomarkers and the receptivity processes. These are the all complex interactions. However, we know that you need very well-shaped endometrium and you need nice embryo, preferably blastocysts and preferably euploid blastocysts to get effective implantation. So what do we need also? We need a progesterone, because without progesterone, you cannot induce the secretory changes to get these blastocysts invased and implanted. It is a very, very important structure in the human reproduction. As we all know that progesterone induces reproductive changes and immune modulation. However, in assisted conception cycles, you need to support progesterone. Why? The most important thing is you are iatrogenically suppressing your endogenous LH levels by using agonists or antagonists. And maybe more importantly, your supraphysiologic steroid levels are going to suppress your LH pulsatility and the progesterone secretions as well. So you definitely need to support luteal phase by using progesterone. If you do not support that, depending on this data, your implantation, but more importantly, sustained pregnancy rates are going to get lowered. Because in the mid-luteal phase, if your progesterone levels are less than 10 nanogram, if you divide by 3 this nanomole m per L, you will get the nanogram. If you get your levels less than 10 nanogram, your ongoing pregnancy rates will be tremendously low. This is a very good illustration. You are going to trigger this HCG from here, and after all, your progesterone is going to rise. And the critical period that we call it the pickup +5, your critical progesterone threshold, which is between 10 to 30 nanogram, is going to be lower during this period. And just during this period, you have to adjust your luteal phase by using some progesterones. And according to the level of evidence, depending on the Cochrane meta-analysis, if you support progesterone, if you support luteal phase by using progesterone, then your live birth rate and ongoing pregnancy rates are going to be high when you do not adjust with progesterone. What we use a lot of things in our daily practice. We use capsules, tablets, inserts, injectable forms, but these are the all absorption patterns of the different kind of progesterone forms. Look at this is the oral capsule, micronized capsule. You get high levels and it's going to be decreased. It's the vaginal gel. It goes around 8 hours and going to decrease. It's the 25 milligrams suppositoires. And these are the oil solution injectables. You're going to see a very, very high serum concentrations. And these are the all subcutaneous injections, pharmacokinetics, kinetic models. To make long story short, if you adjust progesterone with these different kinds, they have equal clinical effect by using these doses, 50 milligram per day, 90 milligram per day vaginal progesterone insert, 300 or 600 per day vaginal progesterone capsules, or 25 milligram per day sub-Q injections. So I would like to tell about the novel progesterone form, which is a synthetic and the retro isoform of the natural progesterone. Tamam, konuşalım. This is a novel form, and this is the isomer of the natural progesterone with slightly different structural changes, which we call it dihydrogesterone. This is a synthetic progestin. The property of this form is 3 times higher bioavailability than micronized vaginal progesterone when you use it orally. That's why you may use 20 times lower doses when compared to micronized form orally, not vaginally. So that's why we use 600 milligrams of vaginal capsules to achieve the effective concentrations, while you may use 30 milligrams of synthetic progesterone, in other words, dihydrogesterone. This is a very interesting slide that these are the sample sizes in phase 3 studies of all available progesterones in the market. You know, after the phase 3 studies, you release the form into market and you will going to release your phase 4. Look, as is the standard of care, micronized vaginal gel or capsules. This is the phase 2 registration trials. Look at the cohort sample size of these studies, 100, 430. And these are the other forms, and these are the all cohort size of the available progesterones. And dihydrogesterone achieved maybe more than 2,000. I would like to tell about the Lotus 1 and Lotus 2 studies, not too long. These are all multi-center, randomized, controlled trials. The first one is the double-blind, double-dummy, and the second one is the open-label study. These studies are just directly compared oral dihydrogesterone with that of vaginal progesterone. The first phase, it compared with vaginal progesterone gel insert, and the second phase, they compared 300 milligram of vaginal progesterone capsules. 600 milligram, 200 milligram TID, the total of 600 milligrams. And they also conducted a post-treatment safety surveillance and follow-up 30 days after delivery. And for the outcomes, ongoing and the live birth rates of all dihydrogesterone versus vaginal progesterone forms are equally effective. And these two studies are the non-inferiority studies with 10% limit margin. And after all, if you put these two studies together and combine the analysis, the data, this analysis of comparative RCTs, randomized controlled trials, demonstrated a statistically significant difference in pregnancy rate between the oral dihydrogesterone and micronized vaginal progesterone. This is a very, very novel study from our group. This is just about to be published with George and the other colleagues. This is a network meta-analysis directly comparing the oral forms with that of the vaginal and the parenteral forms. Let me briefly explain what is the meaning of the network meta-analysis. It means that you are not directly comparing two arms by using the control in controlled manner, but you are going to put a lot of data and indirectly comparing just on the retrospective data. And for the results, we just compared intramuscular form, dihydrogesterone, inserts, and the other forms of the progesterone. The question was, what is the relative effectiveness of different progesterone regimes in fresh IVF cycles? The answer, among vaginal progesterone, intramuscular progesterone, oral dihydrogesterone, and sub-Q forms showed significant increase in live births and clinical pregnancies. What about the safety? I know you have some concerns about the safety regarding the dihydrogesterone. Depending on these two studies, these are two large randomized controlled trials, no clinically relevant differences between the oral dihydrogesterone group and the micronized progesterone group. And this is the latest meta-analysis conducted by Katalinic, included 6 RCTs, and finally, congenital abnormalities with the use of dihydrogesterone showed no significant increase, according to this data that's published in the RBM in the last year. What about the frozen embryo transfer cycles? Up to now, I just summarized you the fresh cycles. And I know you will have some questions about the frozen embryo transfer cycles, especially in the concept of luteal phase support. As we all know, the frozen embryo transfer cycles are going to be in an increasing trend in all around the globe. And the recent SART data also indicated a relatively more live birth rates when compared to the fresh IVF cycles. We have a couple of endometrial preparation methods. The well-known one is the the HRT FET, which we call it programmed FET cycles, that you are using estradiol to form the endometrium and then just put the progesterone into system. And 3 other forms just contains corpus luteum, that natural FET cycles. You may observe the one follicle to grow till 18, 19 millimeters and spontaneous ovulation, or you may induce this follicle by using letrozole or small amount of gonadotropins, and you may trigger the ovulation by using HCG, or you may wait until the endogenous LH surgery. Let me first summarize the current data about the HRT FET cycles, because in my opinion, all around the globe, the HRT FET cycles are the leading form of the endometrial preparation, just due to its easiness and convenience of easy to use and convenience of the patient. These 2 studies are landmark studies coming from United States, that all studies belong to one group, the Shady group in US. The first RCT, they canceled the study, just getting the interim analysis, just because of very, very high miscarriage rates in only vaginal progesterone group, 400 milligrams per day in blastocyst transfer cycles. And in the second analysis, they adjust vaginal progesterone group with intramuscular form, and they sustain similar pregnancy and miscarriage rates. And vaginal progesterone group arm still revealed very high miscarriage rates. So the groundbreaking data was, if you go with only progesterone, vaginal progesterone in HRT FET cycles, you have to adjust your dose individually, maybe not less than 600, maybe 900, maybe twice daily. It's up to your clinical practice, but according to these 2 data, 400 milligrams seems not enough to sustain early implantation period. And accordingly, this is the latest analysis published in FNS. In HRT FET cycles, if you adjust vaginal progesterone with 50 milligrams of intramuscular progesterone in every 3 days, even in every 3 days, it sustains your acceptable implantation and pregnancy rates. So, can we rescue luteal phase by measuring the serum progesterone? Yes, it might be useful, because the data from Spain, Labarta and colleagues already demonstrated this fact, that if the serum progesterone level on the day of embryo transfer or the day before embryo transfer, if it's going to be lower than 9.2, I can make it practically 10 nanograms. You have to adjust the luteal phase by using 25 milligrams sub-Q, 1 shot, and then your sustained implantation and early pregnancy rates are just comparable with those of higher progesterone levels. And some other studies just came from Turkey to support this idea as well. This is our abstract presentation in the recent ASRM, that we asked the question that, do we have any upper threshold? Because, you may adjust your all HRT FET cycles by using progesterone or sub-Q progesterone. The answer was no. Even in the group with progesterone levels higher than 60, the miscarriage rates and the clinical pregnancy rates are not so different from each other. This is our HRT FET cycles pilot RCT. We directly compared dihydrogesterone 40 milligrams, intramuscular progesterone 50 milligrams, and twice daily 90 milligrams vaginal progesterone insert.
And after all, our per ET live birth rates are statistically comparable. What about the latest situation in the natural and the modified natural cycles? The first thing is to trigger or not to trigger in natural cycles. And the second question is to give progesterone or not. This is a very nice RCT from Brussels. Christopher Blochill's team, Sherry Meckens, conducted this study. They directly randomized two groups with HCG trigger or not. And the results were somehow comparable in terms of reproductive outcomes, ongoing pregnancy rates, and the miscarriage rates are also comparable. Whether using artificial triggering or not seems comparable according to this randomized controlled trial. What about to give some additional progesterone in natural or modified natural cycles? We all know that the corpus luteum is essential to sustain implantation process. However, nearly 30% of women reveal ineffective corpus luteum, depending on these studies. I'm not showing these data here. And depending on that fact, they conducted a lot of studies in natural or modified natural cycles, whether giving some progesterone is effective or not. It seems effective, especially including these 30% of women. If you give only 200 milligrams of vaginal progesterone, and when you compare with the group of no progesterone, this is significantly different in terms of live births, about 10%, and it's really important for our daily practice. And this is the latest systematic review of randomized controlled trials in natural fed cycles. Adjusting luteal phase with small amount of progesterone seems to increase the live birth rate for another 10%. So the take-home messages. Fresh ET cycles should be supported. You can support fresh ET cycles with anyone, the vaginal, oral, or parenteral, which we do not suggest to use parenteral forms, especially the in-oil forms, because they are really, they have really severe side effects. It seems vaginal and oral preparations are equally effective in fresh embryo transfer cycles. In fed cycles, especially in HRT fed cycles, you should definitely adjust these cycles luteal phase by using intramuscular or sub-Q. And according to the data up to now, it seems superior than the vaginal. We don't have so much data about the oral forms. We need to wait for a while. It's better to check the serum progesterone levels on the day before the ET or on the day of embryo transfer. Natural cycles, yes, it's better to adjust these cycles with small amount of progesterones. Modified natural cycles, we don't know. There are some ongoing RCTs on that issue. What we do, we usually adjust our modified natural or natural cycles with oral dydrogesterone, 30 milligrams per day. Thank you for your attention.
Thank you, Dr. Capuccio. Let's see the take-home message slide again. We can have 5 minutes for discussion. Could you?
Kim açacak onu? Ben buradan açamıyorum herhalde.
Hakan Yaralı is here. As maybe you know, he has got his team got good, really good papers about the luteal phase support. Maybe we can discuss with him with the Emre. Any question, any comment? I will have some, but I would like to listen to you. Any suggestions, any comment about the luteal phase support, either fresh or frozen cycle or IUI cycle? It's up to you. Slide'ı değiştirdiniz mi? Take-home mesaj slide'ını koyar mısınız? Çok zor bir şey söylemiyorum. Emre sen yapamıyorsun galiba.
Yaptım
değil mi? Ha?
Şimdi şuraya yansıtalım.
Okay, thank you. Let me start. Emre, progestin is necessary for implantation or maintenance of pregnancy. Which one is true?
I think for both implantation and to sustain early implantation. Because why? The luteal placental shift is just going on around 7th week. So you have to adjust these environment to some extent, because we know that nearly 30%, even if you monitorize, even if you trigger, and even if you achieve good appearance during the sonography, reveal very low mid-luteal progesterone levels. And we know that if you remove corpus luteum, according to very past study, the pregnancy is going to be lost. So therefore, it's very important to adjust endometrium with some amount of progesterone just during the embryo transfer on the 5th day of the embryo transfer, which the critical threshold is going to be going down.
You mean to continue the progesterone until 7 weeks, right?
It seems 7 weeks, but in practice, we are going
Do you believe just for the biochemical pregnancies, progesterone deficiency is the etiology or not?
The exact etiology of the biochemical pregnancies may
except genetics.
Yeah, if we exclude genetics, yes. I think the progesterone is essential just during the early implantation process, because, you know, even if you get very high initial HCG levels, if your luteal phase is defective, in other words, if you do not support efficiently, your levels is going to be decreased. Concurrently, you will have some bleeding as well.
Hakan? Hakan Hoca'ya bir mikrofon verir misiniz? Mikrofonu ona verirsiniz. Hakan Hoca mikrofonda kalsın.
Thank you for the lecture. Just for fresh and frozen embryo transfer cycles, fast cycles, the fresh cycles is indispensable for sure. But the issue is that nobody in the world, I would say, monitors the quality of the luteal phase support in fresh cycles. It's not common practice. And the serum progesterone, as dictated by the exogenous administration and by endogenous production from corpora lutea, and also dictated by the quality of the corpora lutea and the HCG given, they're all different. Not all corpora lutea are of the same quality. We give the one HCG, recombinant HCG shot, the bioavailability differs, as the study shown by the Wong. So we recently published a study. So from +3 to +3 to +5, if you drop, then the ongoing pregnancy rate drops significantly, which is encountered 1 out of 3 cycles. So
in frozen cycles, right, Hakan?
In fresh cycles.
This is the fresh cycle or frozen?
Fresh cycles.
Yes, that was published in human reproduction.
So the message is that we should be monitoring but what are the cutoffs? What are the thresholds? Is the absolute value or the trend is important? We do not know. But we should be more focusing on the...
In your clinic for the fresh cycle, what is the cutoff level in your clinic?
We don't monitor. It was just for, research purpose.
Oh, okay.
I discussed with this, Christoph Local in November. And UZ Brussels has just started also looking for the monitoring progesterone levels in fresh cycles. The other issue is, with this oral did for frozen embryo transfers right now, the main problem with this oral product, good evidence, good data, but there is also a need to be personalized. There's the Gersinger's paper, Human Reproduction. It also, using the same dosage of oral progesterone, there is significant interpersonal variation, which it reflects to its with differences ongoing pregnancy rates. In the frozen embryo transfer cycles, I would not consider any cycle, any treatment cycle without monitoring progesterone levels. And with this oral detergesterone, you cannot use progesterone. There's other products which is not available in the daily life. And therefore, yes, oral progesterone can also maybe as a rescue is reported by the crystal blockers group once again. And also for endometriosis patients, these patients, there's only one study by Peter Umaydan that the threshold, the frozen embryo is around 10 nanogram per ml. In endo patients, it might be, I mean, 30 nanogram per ml.
Higher, yes.
We recently abstracted, submitted an abstract to ESHRE with Nilüfer and looked at the HRT protocol, sub-Q progesterone twice daily, looking at the different thresholds, no difference. So with this protocol, at this HRT with twice daily sub-Q progesterone, there appears to be no progesterone resistance issue. I discussed this yesterday with Peter Umaydan on the phone, and he was, that's why the US guys are more, successful regarding the pregnancy because they are using IM progesterone. And by the way, with fresh transfer cycles, another issue, I mean, vaginal progesterone, I would not agree with this conclusion. Vaginal progesterone plus rescue, if needed, is at least is equivalent as the IM progesterone or sub-Q progesterone. So we should be monitoring more the fresh transfer cycles, and for sure, the frozen embryo transfer cycles. And for endo patients, we need more data, whether the thresholds are different. Thank you.
In frozen cycles, do you monitor the progesterone?
For sure.
Okay, how about your monitoring pace and the level?
So
please tell everything to us.
So for the HRT protocol, with sub-Q progesterone twice daily, we published this recently, there appears to be no difference in different thresholds. We still monitor, but you are on the very safe side. If you use vaginal progesterone, we still have vaginal progesterone gel twice daily. I would say in 1 out of 10 cases, you need a rescue. But once you use, the results are comparable. Our threshold for the rescue is 8.75 nanogram per ml. 1 day or on the day of embryo transfer. It doesn't make any difference. The laboratory
to increase the dosage.
To give the, I mean, and if we monitor 1 day prior, so that on the day of embryo transfer in the morning we give a shot. If it is less than 8.75 nanogram, but it's 9 nanogram, 10 nanogram.
Thank you, Dr. Yaralı. In your clinic, for the fresh and the frozen, monitor and the cutoff.
In my opinion, there is an increasing trend about the monitoring both the fresh cycles dynamics and also the ovarian stimulations as well. We just discussed this issue yesterday with human Fatem. They're adjusting the gonadotropin doses just depending on the endogenous FSH levels. It's an interesting topic nowadays. And
do you use or not?
No, we do not use.
And how about the frozen cycle?
Frozen cycles, we definitely monitorize the serum progesterone level the day before embryo transfer to adjust.
Do you have cutoff level?
Yes, we have the practically 10 nanograms, depending on 8, 9. But
for each
10.
indication, doesn't matter, endometriosis, PCO, and other ones.
The endometriosis is a complex issue because we have only one paper just published by the European group that you have to make it the cutoff more than 30. But that paper is, the sample size is quite limited, by the way. I just read the material method of that paper. I think we need to wait more for the endometriosis cases. We need randomized trials.
Yes, validated.
Let's go back to the fresh cycles. This is a very, very old meta-analysis, including a lot of fresh cycles here. Mostly day 3, maybe a small amount of maybe studies are day 5 here. Yes, you may use 50 milligram progesterone in oil, but we conducted an adverse effect analysis in our study that more than 50% of participants suffered from severe pain in the intramuscular arm. However, in our daily practice in frozen cycles, we insist on to use 50 milligram intramuscular progesterone. And depending on our data, it seems to sustain better than others. Like
I mean,
in North America.
Intramuscular, right?
Yes.
And another question, do you believe we have to use the progesterone, which one doesn't matter, for the IUI cycles?
It's another controversial issue. Yes, in insemination cycles, we use them, especially for the gonadotropin cycles.
Depends on the oral agents or the gonadotropins.
It's a fact that we are using the most convenient one, the most simple one, the cheapest and the easiest one. That's why we are modifying our modified fat or natural fat cycles with oral dydrogesterone only, because we have mild study over
The same dosage or the lower one?
20 milligrams in insemination cycles, 30 milligram in natural or modified natural fat cycles.
When will you start?
In
IUI cycles.
Yeah, in fat cycles. If you trigger the ovulation on day one evening, day 3 morning, you will going to start 3 times a day oral dydrogesterone. It's our practice.
Thank you, Hakan. Any comment? Just IUI cycles.
We only use gonadotropins, so there is the data that supports that the meta-analysis, gonadotropins plus IUI, you should be supporting it. Not with the CC plus IUI. We all the time use gonadotropins and IUI.
You use
and we start, yes, as is the case, I mean,
the same dosage. The same dosage.
The same dosage, once a day.
Okay, thank you. Any comment and questions?
But we don't do IUIs, by the way.
Hakan, I know the answer. Please don't say it. And Ümit.
Thank you for the lecture. Would you please comment on the progesterone supplementation for women with adenomyosis? This is one. And the next one is, would you adjust the dose for twin pregnancy? Thank you.
Adenomyosis is also another controversial issue. Both in adenomyosis and in both multiple, higher order multiples.
But just adenomyosis, right?
Yes, let's
just
talk about adenomyosis. 95% of our cycles are frozen, actually, let's confess that. And especially for the endo and the adeno cases, we prefer frozen cycles as well. And if we go with the frozen cycles, even in the adenomyosis or not, we are giving 50 milligram day intramuscular progesterone. That's why, in my opinion, not based on the data, endo and adeno cases should be supported much higher than the standard cases. In twin pregnancies, we generally do not adjust the luteal phase doses.
Jodabi, any comment for these issues? Any comment? Any question?
Do you have any inferior level of the progesterone just the day of the frozen embryo transfer to cancel the transfer?
Yes, it's a debatable issue. No, we do not. We adjust and we rescue the cycle. Some centers and clinicians prefer canceled cycles just depending on the progesterone, very low levels, such as 2, 3, 4. But we have a couple of cases with very low progesterone levels, 2, 3, 5. When they are rescued, their implantation rates are pretty acceptable. And on the other hand, the serum measurements are also unreliable. When did they give these blood samples, blood works? In which lab did they give? It's also, the measurements are 25%, 30% inconsistent between the individuals and between also in the same person.
We have 5 minutes. We have 5 minutes. Reja Hoca, any comment, any question about? You agree? Okay. We have a young attempts in here, Emre. What is the big difference as a physiologically between the HCG and progesterone usage? What is the big difference?
For the luteal support?
Yes, yes.
Okay. The HCG is also in this meta-analysis, but the major problem within the HCG is this molecule has very high and large area under curve, which I mean the half-life of the HCG is nearly 6-7 days, and it induces the progesterone 2 days later. If you support luteal phase with HCG, especially in fresh cycles, you might face with ovarian hyperstimulation syndrome. Because why we avoid HCG in high-risk patients? By mean, on the day of the ovulation triggering, if you have more than 15 follicles, larger than 12 millimeters, you avoid HCG. Why? Because the half-life and the amplitude of the HCG is so high, and it's going to trigger and it's going to stimulate a lot of cytokines from a lot of follicles. That's why in that scenario and in the luteal phase, we avoid HCG and we choose progesterone over that. I don't know whether I answered the question.
Thank you. Christian, any comment? Any question? No. Hakan?
Well, there is data that HCG should not be totally abandoned for the luteal phase support. And first, we have the modified luteal phase support strategies. If you trigger with the agonist and if you apply a fresh transfer cycle, there is huge amount of data that giving, one shot of 1500 HCG rescues that cycle and achieves comparable pregnancy rates. And also even in hyper-responders, not very hyper-response, but in hyper-responders. And also you can be using, HCG,
maybe small
with
amount.
Progesterone-free support strategies. There is 2 shots of 1500 HCG rescue with no progesterone administration. And the Shahar Coast data from Israel, with the agonist triggering, just 1500 HCG, 2 days after the egg retrieval, progesterone-free, no additional support, you would attain, the ongoing pregnancy.
You mean just one shot or every 3 days?
1500. It makes biologically sense because with agonist triggering, 1 shot, 1500, OPO plus today, no additional support, comparable pregnancy rates. So yes, there is still place of HCG for the luteal phase support, but in selected cases. On the other hand, I fully agree, you should be avoiding, HCG in hyper-responder patients. And also the very final note, there is also the Robert Fisher's data, microdose HCG, giving 100 IU per day. It's also biologically that makes sense because if you give the HCG
for the memory
trigger, you will end up the boost of progesterone production in the early luteal phase, does not biologically make sense. With the agonist triggering, giving 100 IU of HCG, microdose HCG, as published in JARC, attains very good pregnancy rates. So in selected cases, still yes.
Thank you.
Yes, these are all the proof of concept studies that, yes, there is.
These are all studies.
There is some place in the small amount of HCGs you may use, especially in the literature you have. For high responders, there is a very nice randomized controlled trial. They directly compared the agonist trigger plus modified luteal support versus freeze-all and deferred embryo transfer. And you know what is the result? The sustained live birth rates are quite comparable, but with slightly higher in the deferred embryo transfer. However, the OHSS and the cycle cancellations are significantly higher in the agonist trigger and the modified luteal phase by using small amount of HCG.
Especially OHSS.
So we, in our daily life, we nearly totally left the agonist trigger and the fresh embryo transfer.
Emre, last 2 questions. Any other question, any other comment? No, last 2 questions. The first one, what is the equivalent dosage? Micronized progesterone, subcutaneous, intramuscular, oral, equivalent.
Okay, are we talking about the fresh embryo transfer?
Yes.
Depending on the level 1 evidence, 30 milligram oral dydrogesterone, 90 milligram once daily vaginal insert, 300 milligrams at least, or 600 micronized vaginal progesterones, 25 milligrams sub-Q progesterone, and 50 milligrams of intramuscular progesterone in oil gives you equal effect in live birth rates in fresh embryo transfer cycles.
Hakan, do you agree with this one? Did you listen to? No. Please listen also, Hakan.
The main problem is that there is
equivalent dosage for all the luteal phase support and fresh cycle. Equivalent dose for each track.
Yeah, I would agree.
You agree?
The issue is with the frozen embryo transfer cycles. All the doses are extrapolated from the fresh transfer cycles, and there is post of data regarding the frozen embryo transfer cycles.
Frozen embryo transfer cycles, especially with the HRT fed cycles, are the perfect samples of luteal phase control. You know?
And study. The last question, why we have to choose the dydrogesterone instead of the others? What is the reason? Because of the Abbott.
In fresh cycles also.
For every cycles.
This question was asked directly to me in the ESHRE meeting as well. And I said, ingesting a tablet is somehow practical and reliable than putting a vaginal insert or injecting a big needle, you know, into your
heart
area. Yeah, that's fine. And the other reason is cost. It's cheap, especially in the baby PPOS cycles.
And could we say, as a solid data and reliable data, oral dydrogesterone is effective as the other ones? No inferiority.
Depending on the data, oral 30 milligram dydrogesterone seems equally effective. Besides, maybe more effective than others in fresh embryo transfer cycles.
Just one really last question. What do you think about the PPOs for the oral dydrogesterone or MPA? Just quick.
It works. It works nice, low cost, but we need some more time, in my opinion.
Do you use the MPA or the dydrogesterone?
We use dydrogesterone.
Dosage?
Yes, the dosage is, in my opinion, it should be 30 milligram. I know a lot of clinicians use 20 milligram.
I used to.
In the early phase of the follicular cycles. However, the ovulation inhibitory dose of the dydrogesterone is 30 milligram, depending on the dose finding study.
Until the ACG, right?
Yes.
Until the. Do you use PPOs in your practice? And which drug and which dosage?
I used to, but nowadays, since we have the preparation that we use, we don't. I normally don't use it.
How about your experience in used to?
It worked. It worked, but nowadays I don't use it.
You, Roger, do you have experience? Do you use the PPOs? Which one? Which dosage?
With 20 milligram. 20 milligram.
Dydrogesterone or MPA? Dydrogesterone.
Yes.
And it's work?
Yes, it works.
It's work. Yes. Okay. Raja, any 20 milligram. I mean the PPOs, right? Dydrogesterone. Hakan, do you have any experience PPOs? Twice daily.
Do fast on twice.
For the first day, right?
Yeah, starting from the, but there is data, the flexible or the convention data.
And it works? It works. Any comment for PPOs? Progestin private ovarian stimulation. Okay, Emre, thank you so much. It's finished. Now I would like to invite you the second session, Dr. Fitnat Topbay Selçuk and Dr. Hümeyra Demirkıran for the chair of the next session without break. Thank you.
Okay, we'll start directly. I'd like to invite Christian Becker to stage. Christian Becker is a professor of reproductive sciences at Nuffield Department of Women's and Reproductive Health at the University of Oxford, and he's the co-director of Oxford Endometriosis Care Center.
Thank you very much, Fitnat. Once again, thank you for the invitation. I'm really enjoying my time here. So I was asked to speak about clinical guidelines, which I've been involved in a little bit in the last few years. Again, these are the disclosures that I would like to announce. They're, well, they're relevant in a certain extent, but none of the funds went to me. They all go to the University of Oxford. So as I said, I've been involved in the ESHRE guidelines. Recently, they were published exactly 2 years ago now, and are freely available. I'm also recently being involved in the update of the NICE guidelines in the UK, which is currently underway. So I was asked to talk a little bit of how these guidelines have been developed, and ESHRE has created a manual of how to do guidelines, which is a 12-point approach. And they go quite systematically through this when the guidelines are made. Now, the first bit is topic selection, and obviously, if we're doing the endometriosis guideline, it's endometriosis. Just to highlight, we did not cover adenomyosis because adenomyosis is not considered a sub form of endometriosis. So, whether there will be an adenomyosis guideline or in the updated next version, we will put adenomyosis in it. I'm not certain, but adenomyosis is a little bit the stepchild at the moment. So then the next step is you need to form your guideline development group, the GDG. In 2005, the first guideline was published, and this was basically a group of experts who came together. I think the way guidelines were done then was much lighter compared to how it is nowadays. So I think we have a much more structured approach. In 2014, the second version of the ESHRE guideline appeared, and I was already involved in this as a member. The last one, as I said, came out fairly recently. Now, some of the people who were involved in the different guidelines, or in the guidelines, some of them stayed on for the next one, and we have one member who was in all three of them. And when I became chair of the current one, I wanted to avoid that we're seen as a kind of group of people who just come together every 5-6 years, have a jolly, and then come up with some guidelines. So I disbanded the entire group, and everybody in ESHRE, so all ESHRE members were allowed to apply if they were interested in taking part in this. So I thought this was a good idea. In a way it was, in a way it wasn't, because we had actually quite a few people who were interested. Now, I think we had more than 200 people applying. And then as a chair, you wonder how you're going to run this. It's impossible to chair meetings with 200 people. So what we then decided to focus a little bit on this. But what was also very important in the guidelines, and I can really only very strongly emphasize this for anything that you do when it comes to patient treatment, involve the patients from the beginning if you want to have acceptance later on, and not as a token patient. Really, you need to have patient representatives who stand their ground against established consultants who actually say what they think, and that also make sure they are listened to. So that is, I think, very, very important. And then also, as I said, in order to make this work, you need to find the right people and also the right size of the group. So as I said, we had hundreds of people, or a few hundred of people applying. What we therefore tried to do is we found that we had 10 or 11 topics that we had to cover. So we decided to have subgroups that actually looked at the different topics, the different bits of the evidence that was there, and which is actually where most of the work was done. And then each subgroup had a representative who then came to our core group meetings, and you can see here how this was distributed. And in the core group, we then formulated the final recommendation and went from there. So once you have formed your guideline development group, then you have to look at the scope. And during the scoping exercise, you define the overall objectives. You have to take into account the potential impact that the treatment recommendations that you come up with may have, and the benefits and risks as well. You have to think about the patient population, also the target users. And you have to also think about what other guidelines are out there. Endometriosis is a funny thing, especially when it comes to fertility, because there's also a fertility guideline. I see this now with NICE as well. So they weren't really interested in endometriosis, and the endometriosis bit are not really interested in fertility. So you have to make sure again that certain bits are not forgotten. So for this guideline, the target users are secondary and tertiary healthcare professionals. So it's not primary care, although we hope that the guideline is still important to them and of interest. The scope, again, as I said, is endometriosis and not adenomyosis. And then looking at the patient population, again, these are women, or it's focused on females and on menstruation as well. Nowadays, we have to be very inclusive, and in order not to upset anyone, you have to really also think about transgender patients. Now, it sounds very very woody if you just talk about people who are born with a uterus for every time. So what we've done is we've come up with a disclaimer saying that we include everybody, but to make it easier, we say, women with endometriosis, but we're not trying to exclude anyone really. So then you ask the key questions. So the core group came together and we looked at all the questions that needed to be asked. We looked at the old guideline, and these questions then were put into a structured format. The PICO that Andrew Horn mentioned earlier as well, so patients or populations, interventions, comparisons, and outcomes. So this is a very well-known structured approach. So a good example for this is the PICO here 1.5, so that's for diagnostic test. So does a diagnostic laparoscopy, which is the intervention, compared to empirical medical treatment, the comparison, result in better symptom management, which is the outcome, in women with endometriosis, which is obviously the patient population. So that is how the questions should sound like. Now, the manual to the guideline says you should have about 20 to 25 PICO questions. We came up with a total of 35 and seven narrative questions because you couldn't really fit them into that structured approach. And we covered 10 or actually 11 topics. The fertility one was subdivided into spontaneous fertility and assisted reproduction. And then this is I think the key step, the most important step here, to actually search for the evidence. Because if you don't ask the right questions and you don't look for the right evidence, you may get incomplete evidence, and then the recommendations you come up with are irrelevant, probably. So this is very important. So you need to have a professional person who does this. ESHRE really nicely provides us with people who do this 24/7. I'll show you in a minute. And then again, they look at this in a structured approach. Obviously, we look at the different levels of quality. Systematic reviews and meta-analysis are regarded as the highest quality. Single randomized controlled trials, the next level. And then observational studies are usually at a lower level. And if you have case series, that's relatively low quality data normally. You have to set your search limits. So, for example, we always went for peer-reviewed literature. You try to avoid abstracts because, as we all know, we often put in abstracts to conferences with very preliminary data. So you have to be very careful that this is actually proper data that you can rely on. Abstracts are, even though they're often reviewed, but they're not properly peer-reviewed, if we are all honest. So you should try to avoid them as much as possible. We did focus on the English language. Whether that's a good thing or a bad thing, I think it's a convention that most publications are in English. There's a lot of Chinese publications, which we're just not possible to evaluate. So that's why we had to come up with this. Obviously, we were looking at humans, not at monkeys. And we would like to, we had to define the time frame. So at ESHRE, I don't know if you know Natalie, so she's the main research specialist. She's also the deputy to Bruno, and I think when Bruno steps back, there's a good possibility that she may take over his job. So she helped us defining the keywords, and then did the search on the usual suspects, so PubMed and Medline in the Cochrane Library, and then we started from day one of these repositories up to the 1st of December 2020. There were a few studies that came out a little bit later whilst we were already in the process, where if people thought this is very important and it might change or support our point, we took that in as well, but there were only the exceptions. So once the evidence is there, we pre-selected with the or it was pre-selected by the research specialist, and then the GDG member, so the clinical specialist, if you wish, is making the final selection. Looking at the abstracts, those titles that are irrelevant are kicked out. But then you check the abstracts for relevant titles, and check for further relevant papers if you have some. Ensure that these papers address the PICO question that you are asking, and then the work starts because you have to read all the papers. Now, sometimes, like Andrew, who had to work on the medical treatment, had to do quite a bit of work, and I apologize again. I had to do that in the previous one, so I know what I'm talking about. There were other sub-chapters where there was less to do, so we may switch over next time a little bit. Once the evidence has been looked at, then these evidence tables are created again by the research specialist with the help of the GDG member. So you have all the evidence available for everybody to look at. These are, I think, also available online somewhere in the very back of the ESHRE websites, where you can actually look at what the evidence was that we looked at. We select the relevant studies, we assess their relevance, summarize the results, and then we have to grade the evidence. How good or how reliable is really the evidence? And when we do this, we have to look at the risk of bias, especially selection bias. So was it really a randomized study, or was this like a semi-randomization? How were patients randomized? Was there proper blinding going on? Attrition bias, so if patients fell out of the study, how was that dealt with? And detection bias as well. And that is all taken into account when you make the decision. And then you use the grade methodology. High means that you're very confident that the data is actually reliable, and very low is where you're not really certain whether there is that the evidence is very strong. So usually the meta-analysis are graded as high and case series as very low. But what can also happen is that, as you can see on the left-hand side, as I said, randomized controlled trials or meta-analysis, they're usually seen as high-quality evidence. But there are also factors that which we have to assess in the guideline group that can actually downgrade the quality of this as well. So, and there are also other things that can increase the quality. So if you have very large effect sizes, you might boost the quality a little bit as well. So at the end, we have to decide how good the quality is: high, moderate, low, and very low. And this is something that when you look at the guidelines, you really have to look at not only what we write, what's the recommendation, but also how strong is the evidence really. We then also decided whether, and based on the quality of the evidence, whether we make a strong recommendation or a weak recommendation. And sorry, I'll pass this. And depending on the strong, on that decision, we then formulate how the recommendation is. So for example, if it's a strong recommendation, the manual says, you can say the clinicians should do this or that, or it is indicated to do this or that. Whereas if it's very weak recommendation, meaning the data is very poor, then we are very, very cautious. So it is conditionally recommended, or the clinician may consider. So it really shows, well, that we're not quite certain about this. But you only can work with the evidence that you have. There are also good practice points. So sometimes where we felt as a guideline development group, there's actually something that hasn't been addressed, but we felt this is practice which works well as part of the experts. We call it a good practice point, which is not proper evidence really, but we felt that it is important to consider. If there was no evidence, but we weren't entirely sure, we came up with research recommendations. And there's quite a few research recommendations in the guidelines as well, which would be helpful, hopefully, to get grandmother money to fund this in some research studies. So we then wrote the first draft and then sent it out to stakeholders. Every ESHRE member was allowed to comment on this. We had a few hundred comments on this, which we had to address. Some of them we really incorporated in the final version. Some of them we thought were a bit silly. And then we came up with a final version, which came out in February of 2022. So as I said, a guideline can only be as good as the available evidence. And that is, I think, very true. And what we've seen really, again, even though we're now in the third version of the guideline, there's still very, very little evidence. And it's therefore very important that we all try to recruit your patients. You know, I see in the UK, Andrew's working hard on the ESPRIT-2 trial to see what effect surgery for minimal or mild disease has on outcomes, on pain outcomes, because we don't have very good data. We all do surgery, we all you know, treat it, but what's the evidence really? And that's a real big problem. So, you know, for example, this is an example that I showed you yesterday. You know, this question about how should we treat patients medically, and we all give non-steroidal anti-inflammatory drugs to our patients as part of the pain relief, but it is based on this one single study from 1985 with, as I said yesterday, 20 patients involved. So 20 patients will make this decision where we treat hundreds and thousands of patients with drugs which have effects but also some side effects. So just be aware when you treat a patient with this. Now the other thing, and I'm almost there, be open to change as well. We did have some changes in our guideline compared to the previous one, and the one where we probably got the most stick for was this discussion about the diagnostic laparoscopy, whether it's necessary or not. So this was all, you know, the diagnostic laparoscopy being the gold standard to diagnose endometriosis is all based on the ESHRE guideline from 2005. So the original guideline that came out then. And everybody who writes something about endometriosis and diagnostic tests and surgery quotes this one paper from Human Reproduction. And that was the evidence at that time. Now, since then, things have changed slightly. So we did look at the guidelines, looked at the evidence, and we did see, one step back, actually, when we looked at the statement about the gold standard, what is this based on? So it is based on 4 studies, one systematic review published some time ago, and it showed that a laparoscopy has a sensitivity of 94% and specificity of 79%. And this is the threshold now for all biomarker studies that we've been doing, for all the imaging studies that have been going on to see whether it's better or worse. And that's, in a way, the gold standard. Now, if you look at the newer, not totally new, but there's newer also since then, studies looking at ultrasound scans, so transvaginal ultrasound scan or MRI, you can see that both sensitivity and specificity percentages are actually very similar and sometimes even better than some of the laparoscopy data from that original meta-analysis. And that's the reason why, as we looked at the evidence, we had to say that for ovarian endometriosis, as you see here on the top, and for deep endometriosis, there is probably something equivalent to a laparoscopy. And I'm sure we'll have some discussion in a minute about this. If you look at endometriosis overall, so which includes peritoneal disease, it's not. So we're still struggling with patients where nothing is seen on imaging. And the other thing we have to consider as well, with a lot of these studies, studies are usually done in centers where you have experts in the field who really look at this, especially with the imaging. This may not represent real life experience. So how much we can translate that data into the real life experience, I'm not certain yet. And that's, again, something that can be discussed a little bit later. All right. So the recommendation for diagnosis, as you can see, is relatively weak still, but we think that ultrasound MRI for ovarian and for deep endometriosis are a tool to identify the disease. So I hope I could give you a little bit of an overview of how the ESHRE guideline was created. As I said, the deadline for inclusion was the 1st of December 2020. So we're now in 24. So this year we have to look at the new evidence again. And if we find that there's significant change since then, we have to do the whole thing over again. If it's only minor things, then we may just update it online. As I said earlier, there were lots of people involved. These are the members here from the core group, where we met a few times. This was all done during COVID, so there's nothing, we fly to some fancy place where we sit together and have a few drinks and talk about this. This was all online. It was quite hard work. But I must say, the real hard work was done in the subgroups, and I'm very, very grateful for everybody who was involved. I know there's people here in the audience who were involved in this, and it wouldn't have been possible without them. And I thank you very much.
Thank you, Christian. We can take questions. We have time. Engin Hocam.
Thank you. This is a provocative question. It will be in the last guideline before this one, year 2005, right?
The one before?
Yes.
13.
No, this is this is 30. Yes. This is the okay. This is 30. Yes. 2005, 13, and 22, right? 20. Okay. If you compare with the other two ones, I say, how can I say is the soft, but I don't know how can I say it. Looks like the year 2005 is the best one, and the other one is the looks like best, but this one is the moderate in my belief. I have some involvement with this one and the other one as a pain medical treatment, but I don't know what is the reason. Maybe because of the COVID. If you look at the whole picture, and not so good answer for the written practice and so good evidence. I don't know. This is not just I told this one to other guys like Dr. Sarıdan, Dr. Lütfi Kizel, Dr. other ones, and they answered to me, but I am wondering because you are the head. Thank you.
No, thank you. I'm very happy for criticism. That's great. Honestly, that's great. So when we switched over from the 13 to now to the 22 one, we had some feedback that people felt it wasn't really applicable. Some of the questions we asked and it didn't work. So we tried to address this. But if you still feel, and again, there's always criticism. You cannot make a perfect one. But if people still feel that this could be improved, I think one of the things that we may do for the next round, I don't know if I'm still going to be involved as chair or whatever, but what I'll suggest is that we may involve ESHRE members to make suggestions for questions, which may address the practical aspects more. Now, and that's fine, absolutely. Whether we can answer those questions then is another, is another unknown, because we have to see what the evidence is. But you're right. And again, the guidelines should be applicable as much as possible. Now, there are a lot of, I mean, we all have this on a day in our daily lives in clinic where we think, well, the guideline says that, but it doesn't really fit this particular patient. And that will be always the case. So whether we stick to what we're doing, you know, we continue the questions that we have and maybe ask extra questions, like sub-questions, is also a possibility. But I think it'd be a good idea to get input from people outside. You know, what other questions would you like to have answered? And we can try to do that.
Andrew?
Christian, is it okay to
Absolutely.
answer Engen's question? I think the reason it looks as if the guideline hasn't evolved as much as it should have done since 2005 is I think guideline methodology, systematic review methodologies has changed and it's become more robust. I mean, you've only got to look at, say, the Cochrane review for surgery, which has eliminated more trials because they're saying that the methodology is not clear. And I think that's happened, but in parallel, our research hasn't evolved as quickly as it should have done. So I think because the guideline methodology is much more robust, we're left with more questions than perhaps we had in 2005. And I think Esri quite rightly have tried to push away from making too many consensus-based statements and stick to the guidance. So that's, I can see what you're saying, but I don't think it's a fault of the guideline group or the methodology. I think it's just that we need to do more research and we need to do more trials.
I have a question. Christian, me,
Right.
here.
Oh, I remember that voice.
So my question is, for example, if you were to do a guideline for adenomyosis, and for some aspects of the disease, let's say the data quality is low, would you still make a statement and say that it's highly recommended if the data is coming from very low quality studies?
So we shouldn't. I mean, so usually if the data quality is low, then it normally should be only a weak recommendation. And then you can say, may consider doing this, because we don't really know.
Okay, so
Yeah.
you stated like that. Okay, thank you. Are there any other questions? We can take one more. No. Okay. Thank
Good.
you.
Thank you.
So I would like to invite second speaker, Tatiana Gibbons. She graduated from Imperial College London in 2019 after completing an undergraduate MBBS and BCS in reproductive medicine. She is a PhD now at Nuffield Department of Women's and Reproductive Health, University of Oxford. Also, she is young ambassador of WES, and her research focuses on advancing endometriosis detection using novel imaging modalities and biomarkers. Now, stage is yours, Tatiana. Welcome.
Thank you. Thank you so much for that lovely introduction. And I'm so grateful to be invited here to speak about endometriosis policies. So this is part of a larger project with the ICMART working group, which is essentially a scoping review on endometriosis policies. I have been asked to speak a little bit about adenomyosis, but I'm going to focus most of my work on endometriosis and kind of see how it plays in. So when we talk about policy, the WHO has defined policy as a strategic vision for health sectors, which either gives them a single document, a set of policies, guidelines or laws that then governments can be held accountable to. And I think when we think, why is this so important? It's really nicely depicted in the Australian first action plan that states that having an endometriosis action plan in place gives tangible improvements to the quality of lives of those with endometriosis, especially in the fact that it can reduce the impact and the burden of disease at an individual and population level. So the questions that I've been asking in my research is, for those with endometriosis, what healthcare policies, delivery systems and rights exist? So I started by conducting a database search, but as you probably all know, the academic databases don't have as much government policies, so we had to move on to a grey literature search. And this included going through all of the 194 WHO member countries and defining which policies they had, which action plans or strategies they had for endometriosis. And then because this field is moving so rapidly, I'm now conducting an updated search as well to get 2023 to 2024 data. So just to give context in terms of the data that we were trying to obtain, so it's mostly publications from governments, but also NGOs, the high-level policymakers. And also we're focusing mostly on endometriosis, and again, policies, delivery systems, and rights. But I really wanted to see how far are these policymakers making sure that individuals are at the centre of their policy. And I think the Scottish Human Rights Commission's panel approach is a really nice way of doing this. So this sees whether each policy is derived using a human rights-based approach. And that really means, so when they're thinking about policy, are they ensuring that those who are affected, so those with endometriosis, are really participating in these policy documents? Have they been given a voice, and have they been allowed to kind of contribute to the formulation of these policies? And have they been held accountable? So is there some sort of method, either by setting a deadline or a timeline, or something to show that they have made this policy, but they are actually holding themselves accountable to it as well? And is it non-discriminative? So are they identifying which groups within their population are kind of, you know, the least benefited at the moment or the most struggling with endometriosis? And are they targeting their policies to try and improve the situation for them as well? And empowerment just means that those are where these policies are meant to be trying to improve their situation. Are they able to make those decisions to say whether they want to be involved or not? And legality is, again, seeing whether there's this legal structure. Is there alignment with EU or UN human rights policies and acts? So the three main ways that I found that across the globe people are operationalizing endometriosis policy is either through action plans, endometriosis laws, or standalone policies. So when we look at action plans, they can be divided into general health plans. So these are the objectives of a country. This is what the country wants for their health system, for their population to improve. And reproductive health and fertility. So this usually stems around family planning and contraception. Women's health is more based around what really affects people on a day-to-day basis. So this could be chronic pain, menopause, and endometriosis. Do they have an endometriosis strategy? So when I went through each of the 194 countries, we found that 191 countries have some sort of national health plan in place. So this is some document that outlines the objectives of their country. And only 97 of these were up to date as of 2023. But only one included endometriosis, and that was Italy. So they stated that they want to support the study and research and the incidence of those with endometriosis in their national territory. The adenomyosis was not included in this. So next I moved on to reproductive health plans, and we can see that 81 countries have a reproductive health plan in place. And 2 countries, which is Italy and France, have included endometriosis within this. So Italy mainly stated that they wanted to improve the education of their service providers to make sure that endometriosis wasn't being missed when patients were reaching them. And France highlighted that they had this action plan, which I'll discuss in a moment. So Italy also included adenomyosis as well. And again, it was around the promotion of education and making sure that healthcare staff had the awareness of the treatment plans needed for adenomyosis. So then when we look at women's health plans, so you can see lots of countries have women's health plans in place, but only Australia, Ireland, Scotland, and England included endometriosis within this. And this is where I really started to look at the panel approach. So have they been participating, patients and experts? And I can confidently say that all of them have some sort of either radical listening exercise, some sort of survey, just to make sure that the voices of those with endometriosis are really being listened to. They can then target what is the needs of our population, and they can target their policies towards that. But then when we look at accountability, I think the Scotland's Women's Health Plan really nicely depicted that one of their main aims was to try and reduce the diagnostic delay from 8 years to 12 months. And giving themselves that target of 12 months, I think, really holds them accountable, and it's something that they can measure their success against. And when we think about legality, again, Scotland's Women's Health Plan has aligned their policy with the European Convention on Women's Rights, Human Rights and the protection of women against gender inequality. So the priorities of them differ depending on, you know, the current infrastructures and what things are needed. I think, again, highlighting Scotland's, I think it was really lovely because they've mapped out the networks that are in place and the care pathways. And one of the care pathways that they realized that they were really lacking on was extrapelvic disease. And that's been one of their focuses, is trying to see if they can improve the treatment and the care for those with extrapelvic and endometriosis. So out of these, England was the only one that included adenomyosis as well as endometriosis. But I think maybe a little bit disappointingly, it was just stating that they were going to include an NHS advice page within their list of current conditions or common conditions in the UK. So then we look at endometriosis action plans, and I'm sure most of you will be aware we have two countries. So Australia started us off, and then France followed a few years later. But we haven't got any action plans for adenomyosis. So if we start thinking about Australia, so this was developed in 2018. So again, it was this participation. They were ensuring that the patients and those who are advocating for the patients, so the parliamentarians, they kind of worked together on this action plan. And I think, you know, the priorities that they outlined are very clear, and it's awareness, clinical management, and promoting research. And I think that one of their strengths is, again, this non-discriminative approach. So they highlighted that the Aboriginal community are really the ones who are falling through the gap, and they wanted to see how they can target their policies to improve the access to care for those individuals. So this is part of the accountability. At 5 years, they produced amazing work, and they've invested a huge amount of money into this action plan. And some of the things that you can see that they've been working on is their awareness campaigns. So they've got lots of digital resources now, but one of their educational campaigns in schools, I think, is really fantastic. So they started in a really small group, started teaching students about menstrual health and endometriosis, and then kind of reflected on that, saw how well it was working, and then have extended it and continuing to improve their program. Clinical care is also a really important aspect for them. So they've now produced the endometriosis guidelines, and they've also made sure that those with endometriosis are able to have an MRI before surgery as part of with a Medicare funding scheme. And they've also been funding amazing research projects. So many of you will be aware of the Imagendo project, which is trying to combine ultrasound and MRI using machine learning. And the HAPPY study is looking at kind of holistic medicines and different alternative approaches to an endometriosis care. So at 5 years, again, this is part of this accountability. They stated exactly what they wanted to achieve. And I don't think they have achieved all of it, but I don't think that's maybe a bit too much to ask for in 5 years. But they have definitely started initiating programs for each of the objectives that they wanted to. So I think everyone, well, at least me, is asking what is going to happen next, because now we've reached the 5-year mark. So this was the first endometriosis plan for Australia, so I'm assuming there's going to be a second. And I think personally what I'd really like to see in the second would be measures of how they are, how are these really affecting the people of their population? So how can they quantify the fact that, yes, they've had educational programs, but does that mean that their population is more educated? Or have they reduced the waiting times because of their improved pathways? So the second endometriosis plan was released by France in 2022. And again, I think it's following the very similar structures. So it's developed by experts, but also patients and advocacy groups. And they again have very clear priorities. So it's research, clinical services, and really trying to improve the rights of those with endometriosis and women's health. And I think one of the key strengths is their research. So they've created the largest endometriosis epidemiological database. So in 2023, they released, it wasn't too much of a report, but it was a meeting summary, which has shown that the way that they're implementing this is by creating steering groups. So each of their objectives has a steering group in place, and then they're able to determine which actions they're going to be doing based on this group. So endometriosis has been included within the funding for research. They've asked each region to define what is your care pathway for those with endometriosis. And I'm assuming that this is so they can try and build upon that and see where the gaps are. They've also initiated lots of training programs for healthcare staff as well. So endometriosis laws is another method that countries have been utilizing. So rather than having an action plan, lots of countries have been passing bills and passing laws for endometriosis. So 11 countries have a bill for endometriosis, and 3 of these countries actually have an endometriosis law. So Colombia passed a law for defining endometriosis as a chronic disability. They also formulated care guidelines and training for healthcare staff. Italy, throughout the period of 2012 and 2021, have had lots of regional laws, but they don't have the same structures in place as an action plan. So in Sardinia, there was an 8-year delay for them to develop a working group. Argentina, so one of their regions, developed a regional law for endometriosis, but unfortunately it was vetoed after 3 months due to insufficient funds. And when you start to compare the laws and the action plans, there's definitely very clear similarities, especially with the action plans, the women's health, the endometriosis action plans and the endometriosis laws are very, very similar, and they align really nicely. But I think the main difference is that with the laws, they focus on what are the aims and the objectives and what are they trying to reach, whereas the plans give a very clear structure of how they're going to get those goals. It almost feels like the laws are a little bit of a step forward, step behind the action plans in terms of just outlining the objectives. There's often they're not specific to the existing infrastructures, and there isn't kind of a indication of how much funding that they're going to be placing on them. And again, there's no timelines for accountability. So I also wanted to really recognize that although countries don't necessarily have an action plan for endometriosis, or they don't have a law, there are amazing things that are going on throughout the world for endometriosis. And I think it's really important to note those as well. But there was a lot of data. So in order to try and make sense of it, I had to do a thematic analysis, and here are some of the codes that I used. But again, lots of the themes that were coming out are very similar to what's on the action plans or on the laws. So it's awareness, economic support, building delivery systems, research, and policy development. So the theme that had the most data, or the countries that were really focusing on, was awareness. So this seems to be a policy that 79 countries we found had awareness for endometriosis. And here are a few of the examples. So one thing that Ministry of Health have been doing are trying to release educational articles on their website, which I think is a really nice initial step. And I don't think it's too difficult of a step. But the next step seems to be declaring Endometriosis Awareness Day. But then there's also been fantastic work being done by advocacy groups. And I think some of the slightly novel ideas I think are also very exciting is, so in Argentina, they had the Minister of Health released a yellow classroom to teach those with endometriosis. And also in the Ivory Coast, they had mobile clinics teaching people in March about endometriosis in shopping centres run by clinicians. So when we think about the delivery system, one of the first things that countries are doing is developing a commissioned working group to try and have a look at their structure, see where the deficiencies are, see where they need to improve their delivery system. But training healthcare staff is one of the key things, and I think that's clearly very important. And then developing clinical guidelines, of course, is very important, as Christian mentioned earlier. And a lot of them are aligning with international guidelines, such as ESHRE. So this is part of, in our group, we have another group, part of us, who are working on a scoping review for clinical care guidelines as well. And we also have research as a theme. So 24 countries had high-level policies on endometriosis research. One of the newest ones is the White House Commission Initiative for Women's Health Research. But there's also some really nice examples of accountability. So in Canada, there's a chair for endometriosis research. So someone's really steering the country's endometriosis research goals. And financial protection is the last of our themes. So 10 countries had high-level policy documents on financial protection. So that could be declaring endometriosis as a disability. So if there's a disability, they're entitled to certain work benefits. Iceland, for example, the Minister of Health had given lots of funds towards subsidizing contraceptives for those with endometriosis. In Spain, they had a fund for egg preservation for those with endometriosis and sick leave as well. And Singapore, one of the examples was fee benchmarking, so setting a limit or setting advice on how much endometriosis patients should be paying for their treatment. So what does this mean in terms of the global policy narrative? So we can look at this by assessing how each country is within the policy development cycle. So starting with, are countries identifying endometriosis as a policy? Have they started to set an agenda? Have they started developing a policy? Have they implemented the policy? And are they now at evaluating the policies? So this is where we've mapped each country within this cycle. So you can see, unfortunately, there's 117 countries that we couldn't identify any data for. We do appreciate that there are lots of countries where, potentially because of our language barriers or because of the way that we search, we may not have been able to obtain all of the data. But unfortunately, 101 of these countries are in low to middle income countries. So this may be where, the global efforts need to be focused upon. So then we have identifying the problem. So this could be countries such as Botswana, whose Minister of Health stated that although they appreciate and they understand that endometriosis is a public health concern, because of the fact that they have to prioritize research or prioritize their funds for life-threatening diseases, they aren't able to prioritize funds for endometriosis. And then setting the agenda is countries such as South Africa that have developed treatment guidelines, but also within their guidelines, they have stated these are the policy initiatives that we believe the country should be aligning to. And we have countries such as that are developing policy. So countries such as, so these are countries that are developing policy either through action plans or laws or passing bills for these endometriosis laws and plans. Implementing policy, so that could be for example, England, who have this action plan in place, and then evaluating policy. So we determined that only one country, which is Australia, because they've had this action plan, but they've also been reflecting in amending their plans and continuing to evaluate this process. So what we've learned from this work is that globally, we really are at the preliminary stages of developing endometriosis policy. So the majority of countries, unfortunately, we haven't found any data on them developing any sorts of endometriosis policy, and especially in the low to middle income countries. So even though Australia has done absolutely fantastic things, they are still within their first evaluation phase. So we really, our most advanced country is still relatively in its infancy. And the 5 countries with the largest populations didn't have any endometriosis policies. The only exception is the US, where they have now recently got the funding initiative, and they've also, at a state level, they have more policies there. In terms of endometriosis rights, there's lots of policies which are trying to align with endometriosis rights. So by trying to have a delivery system, trying to develop guidelines, trying to make sure that access to health is there. And cultural, social, and economics rights, so these could be examples of defining endometriosis as a disability. And reproductive rights are things like trying to ensure that people have reproductive choices, such as Spain, who have the Egg Preservation Fund. So the drivers for policy, I think, truly are the advocacy groups. So, groups like we have here today that are really trying to push the awareness of endometriosis and push the fact that, this is a global problem and we really do need more support for those. But academic societies as well, and political leaders. I think from the research that we found that the common barrier is the lack of awareness, and often this is the first step in trying to get global policy, but also lack of funding and lack of resources. And although I haven't focused too much on adenomyosis, I think I was very saddened by the fact that, that it feels like adenomyosis is even further behind than endometriosis. So the limitations of our work, of course, we tried our best to do all of our searching in English, but also the native language to the country. But of course, there's also Google searches are limited to your countries. So this also might mean that we're not getting as much data from other countries as we'd hoped. It's very difficult to access government documents. And again, adenomyosis data in this presentation is based on endometriosis data. So our objectives are, we have a huge now database of all of the policies that we found for each country, but we are in the process of trying to develop some sort of data repository. So each country, or members such as you are, if once you find endometriosis policy, or you can add this to the data repository, and this gives us a kind of a very clear log of what each country are trying to do. And this can help us with global advocacy, because there really are some lovely structures in place of how some countries have been doing, developing policies, and this could potentially be reflected in other countries. So this is our call to action for all policymakers, that it really is their responsibility to acknowledge endometriosis as a public health concern, to evaluate their existing frameworks, and using progressive realization, so within their resource capacity, trying to continually improve the situation for those with endometriosis to protect their rights and to ensure that these rights are realized. So during this presentation, approximately 4,000 girls have been born 4,000 girls have been born. So we know that many of these will be affected by endometriosis. So although we are truly in the global infancy of endometriosis policy, I really think that developing and implementing and actioning this policy is so important for our existing, but also our future population. So I'd just like to acknowledge the fantastic authors that I've had working on this project with me. And again, thank you so much for having me and listening to my talk today.
Thank you, Tatiana, for that lovely lecture. Do we have any questions from the audience? Ümit Hocam.
Thank you. It was a brilliant talk. I was just wondering, you have shown Spain for the sick leave.
Yeah.
Is it the only country that accepted endometriosis as suitable for sick leave?
So there are lots of countries that have said that if you have painful periods, then you can have sick leave. But to our knowledge, it was the only country that specifically said endometriosis.
Right.
So although, there are lots of countries that you are still entitled, but because of our search being limited to endometriosis, we couldn't include those countries.
Right.
But I think the Spain one is a really interesting concept, because yes, we have this policy in place, but from the research that I've done, lots of people aren't taking up that because they feel that there's still this stigma, there isn't the awareness, so they still feel that like their employers won't give them the opportunity, or they'll look down on them. So even though we have these policies in place, I think we really need to be looking at, how is it really affecting those with endometriosis on a population and individual level.
Right. Thank you.
Thank you.
Surrender Horn.
Thanks, Tatiana. It was beautifully presented on such an important piece of work. Did you look at all at policies for other conditions that are similarly prevalent, like Crohn's and diabetes? And if you did, is there anything that we can learn from them in terms of developing policies for endometriosis and ultimately for adenomyosis?
So I didn't look at any kind of related conditions, but I can see that, when we were kind of looking at the frameworks, especially mental health conditions, were getting a lot more attention. I mean, quite rightly as well, that, I think that there are lots of policies in place that we can kind of align with those, so kind of using the same structures. But I think really that the Australian structure is fantastic, and I think that we can really learn from that. Apart from, as I mentioned, trying to kind of see how those implementations are having on their population, I don't think there's that many improvements that you can kind of use other than the Australian one. I think it's really, really brilliant. So I think each country should just, see how they can align to that within their resources, obviously, because it's quite expensive.
Any questions or comments? Engin Hocam? Thank you. Maybe it's time for you to become a Minister of Health, because yes, we need some policies. We are at the first step, unfortunately. Thank you so much. We will have a coffee break for 20 minutes, maybe 15? No, okay, 10. 10 minutes. 10, because we need more time to discuss. Thank you so much.
Slide'ı buraya veriyorlar. Siz buradan
Görebiliyoruz.
slide'ı, evet, kontrol ediyorsunuz.
Buradan ileri alan bu. Dur.
Nasılsınız hocam?
İyiyim, sen değil misin?
Ben de çok iyi, teşekkür ederim sana. Gözleriniz çok güzel.
Öyle mi?
Çok güzel parlıyor.
Çok teşekkür ederim.
Ne demek, rica ederim.
Bu ileri, bu geri.
Evet hocam.
Bu da pointer alan değil mi?
Evet hocam, o da noktayız.
Tamam,
Şunu
çok iyi.
isterseniz açayım hocam, test etmek için.
Yok, aç peki.
Siz oradan açıyorsunuz değil mi?
Evet.
Biraz.
Hocamın sırası geldiği zaman biz hazır edelim.
İleri.
Şimdi tekrar deneyin hocam.
Buradan da kont bakabilirsiniz hocam. İleri gelir gidiyor.
Kontrol kullanmak için hocam bize
öyle ekranda da şu an gidiyorsunuz hocam.
Çok iyi gördüm. Tamam. Şimdi anladım. Dersimi çalıştım şimdi.
Çok iyi hocam. Önceden bir prova yapmak kısa da olsa.
Hayatım benim prova. Tuvalete dahi gitmeden prova yapmak.
İnsan bir şey yapmaz hocam. Hiç böyle sağ olun.
Salonda kimse gelmedi. Az sayıdayız. Şimdi bir çaldırın bir dakika.
Sayın Başkanlar, Başkanım. Ricamız var.
Tamam. Tamam. Yes, good afternoon, everybody. We are at the last meeting of this session. And in this session, we have 4 excellent speakers. They will define the controversial issue in clinical practice of endometrioma and in adenomyosis. First speaker is from Ankara University, Professor Bülent Berker. He's a specialist on endoscopic surgery and in reproductive medicine. He will defend the endometrioma-related infertility surgery as a first approach. Please, Bülent.
Thank you so much, dear colleagues. It's my privilege to be here, and I really thank to the organizing committee for this beautiful meeting. My topic is surgery as a first approach in the case of endometrioma-related infertility. As you all well know, endometrioma is a benign but chronic inflammatory disease which causes pain and also infertility. And it's characterized mostly in reproductive aged women, and 10% of those women have mostly endometrioma. However, it's much more common in infertile patients, and approximately 2/3 of these patients have endometriosis patients have endometrioma. Does endometrioma cause infertility? In fact, this is an important question because can we say that endometriosis or endometrioma per se has no negative impact on fertility? I think we cannot say this because the increased prevalence of endometriosis among subfertile women indicates that endometriosis impairs reproduction, but the reasons that we could not totally elucidate today. Furthermore, surgical management of endometrioma in the setting of infertility without pain is a matter of debate. How endometrioma causes infertility? The exact pathophysiology still is not well known. However, there are some mechanisms suggested like distortion of the pelvic anatomy, chronic inflammation, and decrease in follicular reserve via the way of burnout effect. So, patient comes in front of us with two main complaints. One of them is infertility, and the other one is pelvic pain. The argument for surgery is clear when the problem is pain. However, it is somewhat suspicious in the case of infertility. And in regard of infertility management, the approach to endometrioma has been changed considerably during the recent years, and currently the focus of infertility treatment has shifted toward the IVF. Instead of correction of the pathology, I mean endometrioma. What is clear in case of endometrioma is the application of endoscopic minimal invasive surgery, and currently the laparoscopy is considered as the gold standard of treatment approach. And during laparoscopic procedure, which includes freeing the ovary from adhesions, hysterectomy or ablation of the cyst, and meticulous surgery with the least possible injury to the normal ovarian tissue. Also, in addition to these applications, we should always evaluate the pelvic, peritoneum, and clear the endometriotic foci. Some clinicians at the end of their surgical procedure use the endometriosis fertility index. I don't mean that we should always use this index, but some clinicians use, and which includes both historical parameters like age of the patient, infertility duration, and previous pregnancy history, and also surgical factors like the positions of the tubes and ovary. Although we do not have RCTs considering the reproductive outcomes of surgical and expectant management of endometrioma, in the literature, the mean pregnancy rate reported 50% following surgery is really a good scientific proof that the operative treatment should be first undertaken in order to give the patient the best chance of conceiving naturally, spontaneously. However, most patients are today referred to IVF in the case of endometrioma-related infertility because surgery needs a certain skill and it costs something. For example, decrease in ovarian reserve, recurrence problem, and also incomplete surgery. Because of these reasons, most patients today skip to IVF. So, still, we do not have a general consensus about the appropriate therapy of endometrioma-related infertility, and dilemma is still continuing. And some physicians, some clinicians believe that the use of laparoscopy to treat endometrioma who suffer from infertility should be superseded by IVF. However, some other physicians like me believe that we should still emphasize the importance of keeping laparoscopy in the management of infertility equation. Does the endometrioma surgery increase the probability of pregnancy? Do we have RCTs regarding this? In fact, we have very small count of RCTs, and those RCTs are related with superficial peritoneal endometriosis, and they show that surgical, you all well know these studies, they show that they increase the possibility of pregnancy after surgical correction. So, what this shows us that peritoneal, or the other name is superficial endometriosis, is really an important risk factor for infertility. So presence of pelvic endometriosis increase infertility. So the question is, Is it possible to see an endometrioma is an isolated case? In reality, is it possible? Studies shows that this is not a possible case, and most of the endometriomas are together with peritoneal endometriosis. And since we have the RCTs that shown that surgical treatment of peritoneal endometriosis increases the probability of spontaneous pregnancy, depending on this evidence, we can say that use of laparoscopic surgery may improve the future natural fertility in endometrioma cases also. However, many recent studies have generated concerns that managing endometrioma surgically could be harmful to the ovarian reserve and also subsequently adversely affect the IVF outcomes. So, women with endometrioma-related infertility faced with a dilemma when choosing the appropriate therapy, whether she will go surgery or undergo IVF. And in reality, we know that however you do the surgery in a very well way, surgical treatment is associated with a decrease in ovarian reserve, both in respect of AMH and also intrafollicular count, because you perform hysterectomy. And if the case is bilateral, the situation is much more worse during hysterectomy application. So, as a result, surgical treatment is not recommended in patients with limited ovarian reserve or in elderly. Due to the negative impact of hysterectomy on ovarian reserve, less invasive modalities of endometrioma surgical treatment with less impact on ovarian reserve, such as sclerotherapy or ablation, should be further explored. And because of this, a new technique has been described called combined surgical treatment of endometrioma, both using hysterectomy, partial hysterectomy, not complete hysterectomy, and also ablation. And we have now currently RCTs and meta-analyses that shows that when we apply ablation, the decrease in AMH will be much less. So this shows that surgery must be performed very meticulously to keep a minimum, if any, damage to the ovary. And the technique of laparoscopic hysterectomy may not be the gold standard and should not be automatically, systematically performed. And we should not, of course, we should not forget that if we leave the endometrioma without touching, it may per se itself can cause a decrease in AMH level, as we have discussed in the morning. And the mechanism is, as you all well know, is the burnout hypothesis coming from the chronic inflammation. So, in an infertile patient, when we confront with such a patient mostly asks this important question: could I conceive without IVF? And first treat my endometriomas, and I want to get pregnant by myself. So, do we have such studies in the literature? Many. And for example, this is a very well-known study from Italy, and you see approximately in 1 year, you see a 40% of spontaneous pregnancy in advanced cases, also together with endometrioma. And of course, I want to stress that the management depends, of course, on the age of and the reserve of the patient. But we do have pregnancies after surgery, natural spontaneous pregnancies, and most of these pregnancies occurs in the first year following the surgery. Another recent study, prospective observational study, demonstrated that if we use EFI, and if the EFI is good, score is good, with a high score, approximately 40% of spontaneous pregnancy is possible, and again, most of the pregnancies occurs in the first half year following the surgery. So when we evaluate the literature, we see that, in fact, the pregnancy rates are not such different between two different modalities, IVF and surgery. Approximately the same, but surgery provides us what natural, spontaneous pregnancy, but it takes somewhat longer. And we have shown that in a recent paper, the size, number, and bilaterality of the endometrioma do not affect the spontaneous conception rate if we follow the meticulous laparoscopic surgery techniques. So, in an infertile patients with endometrioma, how we choose whether we will use ART, IVF, or surgery? Of course, the age, ovarian reserve, tubal factor, sperm parameters guide us, and we can choose either surgery or IVF. We should discuss with the patient, we should individualize the treatment of endometrioma-related infertility patient. Patient's desire is important. We cannot say that all endometrioma patients should undergo IVF and some other parameters, as you will see. Another important point is the oocyte quality. And some authors say that there is a decrease in the oocyte quality in endometrioma cases. However, in a recent paper I have written, we showed that there is no increase in the oocyte quality. The increase in quality is related with age, is a function of age, like decrease in quantity. So as the age increases, both quality and quantity decreases, as in all patients, endometrioma case also. So in younger women with good reserve, you can choose surgery. By the time passes, in elderly women or women with less ovarian reserve, you can choose IVF. Also, if patient or you preferred IVF, and recurrent IVF failure case, if you do not, unfortunately, obtain pregnancy, again surgery will help you. This is, I think, the only paper that I've written about this subject, and surgical treatment of endometriosis improves outcome and allows couples to conceive without IVF. What about the guidelines? Guidelines say that the recent ESHRE guidelines say that still surgery has a place and you cannot escape from surgery, and you should not forget surgery. So clinicians may consider operative laparoscopy for the treatment of endometrioma, although we do not have RCTs. In conclusion, referral of a couple for IVF treatment should not be based only on the diagnosis of endometriosis or endometrioma, but mainly on concomitant fertility impairing factors. Surgery has a fundamental role to play in the treatment of endometrioma, and hysterectomy, according to our general, contrary to the general knowledge, hysterectomy should not be our routine practice. However, in case of recurrent endometriomas or decreased ovarian reserve, the risk of surgery should be discussed with the patient. Surgical treatment is not recommended in patients with limited ovarian reserve or in elderly, and in this case, the IVF will be the wise solution. Last but not the least, only surgery of the disease can avoid further impairment of fertility caused by the progressive nature of the disease, and offers the possibility for a spontaneous conception and also, when present, relief of pain. Thank you very much for your attention.
Thank you very much. We will discuss later.
So first of all, I would like to invite Professor Hakan Yarılı, and actually it's a very privilege for me to invite him because he's my senior. He is also my mentor. I learned many things from him with regard to academic fields. So he will be talking about the management of IVF and endometrioma. Professor Yarılı.
Thank you, Gürkan. I initially would like to thank the organizing committee, and in particular Engin, for his very kind invitation. And also with this opportunity, I would like to congratulate Engin for his great motivation and enthusiasm for the recognition of all aspects of the disease among not only physicians, but also the patients suffering from both diseases. So, ben slaytlarımı alabilir miyim rica etsem? So the debate on what should be the primary treatment of OMAs associated with infertility has been on the screen for decades. And in medicine, we should not be polarized. We should not be polarized, and we should be avoiding the all or nothing fallacy. And also this applies to the management of OMAs. So in my agenda, I will be first comparing the efficacy of the two approaches. First of all, we should be recognizing that there is a background spontaneous fertility in patients suffering from OMA. And this study with more than 200 patients with unilateral OMA and looking at the rate of spontaneous ovulation in natural cycles from the affected versus the non-affected site, reported a similar rate of ovulation in the affected site, irrespective of the size of the OMA. And moreover, this study reported a conception rate of 43% in 6 months. But remember, keep in mind that this study enrolled not infertile patients, just patients walking in the street, not suffering from infertility. And this slide has already been shown, quoted, reporting a pregnancy rate of 50% following laparoscopic excision of OMAs. But we should also skeptically assess this 50%. First, there is selection bias. So for those included studies, inclusion of women not seeking fertility, not wishing to conceive, would obviously inflate the results and creating selection bias. And also surgeons with suboptimum results following laparoscopic excision might be less willing to submit their data to be published, creating publication bias. Dropouts have notoriously have worse prognosis, and therefore exclusion of dropouts would erroneously inflate the merits of surgery. And also some of the patients, although they conceived via IVF. And in a limited number of studies, this discrimination has been made. And also the lack of control group, not controlling the background spontaneous conception rate is a limitation of those studies. And therefore, the absolute benefit of surgery in 12 to 18 months may be only 25% rather than 50%. And this chance of pregnancy might be attained with single attempt of IVF, fresh or frozen. So we may conclude that one attempt of IVF, either fresh or frozen, would attain at least the efficacy of surgery
with 12 to 18 months follow-up. So it is as efficacious as surgery. And also, with this opportunity, I would like to stress the impact of the disease on various aspects of IVF as evidenced by the recent emerging data. And OMA's endometriosis is unremarkable to ovarian response, might be a slight reduction in OMA's greater than 4 centimeters. Follicular cytogenesis is not affected. The oocyte quality is preserved. The fertilization rate is good as non-endometriosis patients. Embryo quality is good with no surge in reproductive rates. And most importantly, the implantation rate is as good as those patients with no endometriosis. And therefore, the main relevant challenge in infertile women with endometriosis undergoing IVF should be the prevention of the surgical damage of ovarian reserve. What about recurrence and progression? Well, following surgery, up to 30% in 2 to 5 years, we might have the recurrence. And what about the effect of the multifollicular development on the progression of the disease? Mild, if any, as also was written by the recent ESHRE guideline. What about the safety and risks? Well, with the surgery, there might be the minor and major complications associated with surgery. With, generally speaking, for IVF, we are speaking about completely OHSS-free clinic. And with single embryo transfers, with single blastocyst transfer, the risk of, the multiple pregnancy, basically twin pregnancy, is less than 10%. And we have bulk of evidence. Whatever you do surgically, the greatest impact would be by the excision laparoscopy speed, but also with, the ablation, but even by the sclerotherapy, you damage the ovarian reserve. And this damage, just taken from the recent meta-analysis, is there in the early, in the intermediate, and on the last term. So by 9 to 18 months, the decrease in AMH level is greater than 2 nanogram per ml. So with surgery corrected by the decline by female aging, with bilateral OMA surgery, the decline AMH is equivalent to 7 to 10 years of chronological aging, which we should be avoiding. And obviously, this detrimental effect is also affected by other factors, including female age, the size, bilaterality, the experience of the surgeon, and whether the surgery is repetitive or not. And also, I should also submit that the partial, this detrimental effect on ovarian reserve is also induced by the OMA per se, without surgery. We should keep in mind, those who are involved in IVF do know that there is an infinite relationship. Between the number of eggs and cumulative live birth rate. But the vitrification techniques with the survival rates exceeding 98%, the number of oocytes is a very, very, very important throughout all ages. And the main determinant, obviously, for the number of oocytes is the ovarian reserve. What about the risks for the pro-IVF site? Oocyte retrieval difficulties, infection of OMA, and missing and occult malignancy. Well, with the OMA, there might be distortion of the anatomy, and due to the distillated ovaries, it might be difficult to do the egg retrieval. And also, it has been reported that there might be you might be running the risk of threefold increased risk of incomplete aspiration. And the accidental contamination with the OMA content, which I don't think is a concern. then if there is a case, then you might be, preparing the vagina with the betadine and also administering antibiotics and continuing antibiotics for a while. Despite all measures, you might still be running the risk of ovarian abscess. But still one might, with surgery, one might expect aspiration of all follicles after surgery, but also to have less follicles to aspirate. So the effect is modest, and that does not justify routine systematic surgery before IVF. And in line with this conclusion, there has been a recent study looking at different sizes of, omas, less than 2 centimeters, 2 to 4, and so on, and with and matching all these subgroups with AMH and female age. And then the conclusion is that the primary outcome measure is the number of eggs retrieved. The number of eggs retrieved and all other parameters are comparable between the subgroups. And most importantly, when you make the multivariate logistic regression analysis, and it's not the size of the OMA, it's not the size of the OMA, but rather whether there is the presence of previous surgery or not that dictates the number of oocytes. Once again, we should be doing our best to avoid surgery-induced damage to the ovarian reserve. Missing an acute malignancy is a concern, but still, that is not high enough to justify systematic surgery. What about the cost? Cost also should be taken into consideration. Obviously, the cost of surgery and IVF should be considered in the local circumstances, and there are different models in this context. That the accessibility of IVF is a problem worldwide. It's also a problem in our country, and there are different models looking at the affordability and accessibility using different formulas, and Turkey is there. And also that also applies for surgery, but this should be also taken into account. What about the time to pregnancy with the new terminology, time to singleton healthy live birth? And when the patient, they show up, they would like to get pregnant the next day. So that is an important issue too. And there is no comparative data, but it is expected, obviously, to be shorter with IVF. So coming back to the question, which option, which modality should be the primary approach for the management of OMAs? We should not be polarized once again, and we should be avoiding the so-called therapeutic illusion, the tendency of human beings to overestimate the effects of what they do. And we should be more patient-centered and taking into account all these factors, which I will not repeat. And then this slide has already been shown. And for those patients, the young patients with shorter duration of infertility, with no apparent tool factor, and with no male factor, surgery might be considered. But I personally, what I do personally, even for those patients, I recommend IVF. But surgery might be an option for such circumstances. Otherwise, IVF should be done. If the surgery, if you do the laparoscopy, and it has been already quoted, the endometriosis fertility index is not favored, then one also can be converted to IVF. And that also has been written in the very recent ASHRAE guideline. So to conclude with, both IVF and surgery may have place in the primary management of patients with OMA, taking into account the relevant parameters. A decision made on transparent and complete information and freedom is required. Mounting evidence suggests that surgery for endometriosis is potentially prone to harm the ovarian reserve, even more than the disease itself. And the main relevant challenge should be the prevention of surgically induced ovarian damage. Thank you.
Thank you for the nice presentation. Is there any comment or question from the audience?
Maybe first of all, Bülent, do you have any comment to do it? Would you come to the...
Gel sen de buraya Bülent.
Yes, do you have any comment to do it? Bülent, you accept all Hakan said?
There is a question.
Yes, question, please, yes.
Thank you very much for your nice presentations. I have a question to Dr. Bülent. For big endometrioma and bilateral endometrioma, you are in favor of surgery. There is, I think, no robust data, strong data about laparoscopic sclerotherapy. Whether performing cyst excision for big endometrioma or bilateral endometrioma or recurrent endometrioma cases, do you think that it is an alternative surgery or alternative route performing a laparoscopic atenosclerotherapy? What do you think? Thank you very much.
In case of bilateral endometrioma, of course, the situation is very terrible, and we are afraid to decrease the ovarian reserve. So, in those cases, in my practice, I'm not applying, totally. So, in those cases, if possible, on one side, I may apply sometimes sclerotherapy, and on the other side, combined technique, both cystectomy and mostly ablation. I'm using ablation as a bipolar technique without overcoming the 30 volt of energy. So in those cases, if AMH level is good, patient is desiring pregnancy by a natural way, I'm applying surgery in a very, very meticulous way. Sclerotherapy and both combined technique, not cystectomy.
Maybe you might be quoting the study on sclerotherapy by your university. So what about the results, the available results?
Thank you so much, my teacher. In our faculty, we are applying sclerotherapy both transvaginal and laparoscopic way, and I am on the arm of laparoscopic treatment sclerotherapy. In fact,
so the arm says the vaginal aspiration and sclerotherapy.
Yes.
And the other one is
laparoscopic total sclerotherapy, again without ablation.
So what about the control group?
Control group, we do in fact, endometrioma patients are mostly escaping from physicians, doctors.
But
so
the control group might be cystectomy, but no cystectomy, right?
Yes. In the future, approximately currently we have 40 patients, and sclerotherapy is working very good. But sclerotherapy, mostly if we apply vaginally, those patients are much more close to IVF. If they want IVF much more, we are applying vaginal sclerotherapy in order to decrease the pressure. But if they have some time for the pregnancy, if they give 1 year or somewhat, we are applying mostly laparoscopic procedure.
So this is not a randomized control trial, right?
In fact, it's not. It's not possible because you have to get an application for the ethics committee, and they want so much money.
In big endometriomas, for example, 10 centimeter, do you think that does it work for laparoscopic atenosclerotherapy? In big endometrioma sizes.
In large endometriomas, I mostly perform combined technique. Because after all, there will be a huge mess, and patients do not like, and some physicians tells that they only have made suction, and they did not anything, so they can accuse us. But if it's less than 10 centimeter, I'm applying sclerotherapy.
But still, we should also quote that with even sclerotherapy, there is a study by Roman that reports in 6 or 9 months after the laparoscopy, combined technique sclerotherapy, the decrease in AMH is 1.3 nanogram per ml. So sclerotherapy is, yes, associated with decreased ovarian reserve.
In fact, in order to prevent the recurrence after sclerotherapy, you have to ablate the point that you enter to the endometrioma. So, I mean, of course.
But still with this approach.
Yes.
I think like the only thing to do the bilateral cyst ablation by sclerotherapy or by other techniques is the difficulty to access to the follicle. If not, there is no indication if it is bilateral and the big endometrioma. And also, when you use the combined technique by bipolar energy, the decrease of AMH level is much more than when you use the other technique like laser or like alcohol, because the heat transmission of the bipolar is much more than the other techniques.
I fully agree.
Yeah. Any other question, please, Engin?
Hakan, you said damage to the ovary after the surgery, roughly 8 years aging. This is the first time I heard. How did you get this information, this knowledge? If I understand correctly, you say you have the surgery, you damage the ovarian reserve, roughly 8 years aging of the ovary.
So this sentence is quoted, is given actually by the meta-analysis by Yunis. So following published in American Journal of OBGYN. And in this, so they are looking for the decrease in AMH is 2.1 nanogram per ml. So, well, between, age 30 to 40, the decline by aging process is in AMH is 5% per year. And this, for antral follicle count, this is 0.4. So if you just take into consideration this decrease by natural aging, and then take the decrease in AMH, this corresponds to this figure. And it is written in the discussion. So the bilateral surgery of OMA is equivalent to 7 to 10 years of chronological aging, corrected by female aging.
But in this article, it's criticized by the other authors, and it's just the assumption. It says, and without age effect, around every year we have this decrease. That means maybe there is no evidence behind of this one. Just he says in the same article in the year 2022, it's 21. It says just maybe 7 to 8 years and harm. This is really important because that means every surgery has a bad conditions for the ovarian reserve. It's very, very important, I believe, in our practice. If you accept this one, this is the rule.
But Engin, let me jump. The detrimental effect of surgery is there. And the major strength of Yunis study is that within the same woman, they monitor the AMH before surgery, early, intermediate, and late period. So within the surgery. And since there is intra-patient, controlling the confounders, all confounders, the surgery, the ethnicity, and whatever then this is a major strength of this study. And the evidence is there. Yes, you make the harm, irrespective of how you are experienced. And the level of, detrimental harm is there if you are not experienced. So
but the problem, we don't know the more than 1 year's data. Only literature, we have just 1 year recovery period. We don't know 3 years and 4 years later, what is the AMH level? Is the same level, is the decreased level, or the more decreased? We don't know.
But AMH would not recover, AMH would not recover. So one of the conclusions of this study was, inconsistent from the previous ones. The AMH would not recover,
With your permission, may I add something? From a study from Turkey, the error study, the presence of endometrioma decreased approximately AMH level 25% at least. So presence of endometrioma is a lethal damage to the ovarian reserve, but we should not forget.
Good to hear.
But we should not forget that bilateral endometrioma without, For example, the 2006-9 study of virtual knee, it may be an overestimation for the application of surgery. But I think this sentence by Dr. Hakan Yaralı may be an overestimation that surgery decreases 10 years of woman's age. So I think in bilateral endometriomas, we should know that when we apply surgery, especially cystectomy, there will be a 60% decrease. If it's unilateral, there will be a 40% decrease. Whatever you did the surgery, but I want to stress that in ASHRAE guideline, it's not written in endometrioma infertile cases. It's not written. The technique of laparoscopic surgery is not written. In pain patients, cystectomy is declared, but in fertile patients, the technique is not mentioned. So we should not apply automatically cystectomy. If you want to preserve the reserve ablation technique, either laser or normal energy, you should apply combined technique.
I think that Dr. Muzi is also here. He did a lot of publication on this issue. What do you think about it? What do you do? Do you have any recommendation?
Thank you for giving me the word. I would obviously conclude with the same issue. The management should be personalized. I like most what Bülent said on when he has the bilateral endometrioma. Okay, we decided she should undergo surgery. That's another issue. But when we have surgery for bilateral endometrioma, I do the same thing. Actually, not your technique on one side, sclerotherapy, because I don't think there is a lot of data on sclerotherapy or some data. You do sclerotherapy on one side and combined technique on the other side. I do stripping, classical stripping on one side, the larger one maybe, and ablation with either laser or bipolar on the other side. Because I don't think sclerotherapy is still, there's not all this data on that.
Thank you. Any other questions? Yes, please.
If you cannot avoid surgery, when will you do ART, IVF after the surgery? And it depends on the patient's age? What do you do? What's your experience?
I mean, if I misunderstood, first you did surgery?
You do the surgery and she fails following surgery. Then what should be the time period to consider IVF?
Do you need to start IVF for 6 months or
surgery,
1 year? Or
why we did the surgery? We did the surgery because we want to give the patient the chance of natural pregnancy. But as you know, by the time passes, there will be an increase in the risk of recurrence, an increase in the risk of those what we do not know, because there is a chronic inflammation. And as you know, we do not know how endometriosis or endometrioma in patent tube patients, how they cause infertility, we do not know. So I believe in the chronic inflammatory foci. So at least 12 months later or 1.5 years later, you should pass to the IVF after surgery. But maximum time, this is the maximum time.
Thanks.
Okay, thank you very much for the speakers. Thank you very much. Now we move to the second subject. It is the IVF in endometriosis and adenomyosis. Freeze all
Recording in
versus
progress.
fresh transfer. The first is from France. Dominique de Ziegler, I think that everybody knows him. He was born in a very nice city of France, in Nice. And then he moved to United States in California. He did his training in the San Francisco, California University. Then he came to Genève. And then he moved to Paris and the University Paris Descartes. He worked in Hôpital Cochin de Port-Royal. For many years until 2017, he was the head of the department. And actually, he's working as a university consultant and the emeritus professor in Hôpital Foch in Paris. And he published more than 230 articles, many book chapters, and many awards. Do you hear me, Dr. Dominique de Ziegler?
Yes, I do very well, very well.
Yes.
Shall I go ahead?
Yes, you go ahead. Yeah. IVF in endometriosis and adenomyosis, you defend the freeze-all transfer strategy, please.
Hello, everybody. I'm talking to you from south of France. So the weather is beautiful. It's about 20 degrees Celsius, 68 Fahrenheit. Beautiful weather. It is an honor to participate to your meeting. Lots of distinguished speakers. And my topic is going to be to talk to you about the use of freeze-all and deferred embryo transfers in IVF with endometriosis. Those are my co-workers at Hôpital Foch, and what I will remind you is that over the past decade, four new features have modified how we see endometriosis and IVF. We need to cannot go back, I cannot return. Okay, we need to actually have new mode of diagnosis for endometriosis because we don't do a diagnostic laparoscopies anymore. And these being said, let's dwell for a second on the pathophysiology of endometriosis and adenomyosis, and in particular, the issue of endometrial receptivity. And endometrial receptivity has been addressed in a series of articles which we had in Fertility and Sterility. But actually what we showed is that in HRT replacement cycles, endometrial receptivity is not altered. We don't know anything about fresh cycles. We don't know anything about frozen cycles conducted in natural cycles. All we know, all we have learned, is that receptivity is not altered in case of transfers conducted, frozen transfers conducted in HRT protocols. The work by one of your compatriots, Dr. Balloon in Chicago, has actually shown the essence of the pathophysiology, which actually resides in the endometrium itself, where you have alterations of the epithelial cells with mutation, including oncogenic type of mutation like KRAS, as well as epigenetic alteration of the stromal cells. Now, the remarkable work of Dr. Balloon indicates that the pathophysiology of endometriosis and adenomyosis is similar. In one case, those altered cells are shed backwards through the tubes and go into the pelvic cavity, and in the other case, in adenomyosis, just penetrate in the endometrial thickness and invade the myometrium, as you see here. This actually is the same pathophysiology for both diseases, the same mutations, which, by the way, are different from what you find on fibroids, but they are similar in the pelvic lesions of endometriosis in the endometrium and in the adenomyosis areas in the myometrium. those activating somatic mutations of the KRAS type and others is the common denominator to endometriosis and adenomyosis. So you have lots of alteration in the endometrium. And our objective, obviously, is to do IVF and to have implantation and to have success. Now, medical treatment is not effective for infertility. It's effective for pain. It's effective for preventing recurrence after surgery. But my message here is this. The common denominator of treatments is not to drop estradiol levels, as we sometimes thought, but actually is to block ovarian function. So the common denominator to the disease itself is ovarian function. And if you block ovarian function, you have an improvement of the symptoms and you have an improvement of the lesions. So remember this message when we go back to the final justification for frozen embryo transfer in case of endometriosis. Now, the essence of the pathophysiology is this. In an in vivo fertilization, the sperm and the eggs is in contact with the pelvic environment, which is toxic because of inflammation. Now, IVF allows you to bypass this environment by collecting the eggs before they ovulate, and the sperm is obviously given in the lab. So the embryos and the oocytes and the sperm are not exposed to the pelvic environment, which is toxic. And therefore, on one side, you have endometriosis altering in vivo fertilization, but in vitro is not altered. And I'll give you evidence that actually the oocytes are not altered. This is a work that we did in collaboration with the group of Richard Scott, indicating the aneuploidy in women with endometriosis in light blue and women without controls. And you see that aneuploidy increases with age, which we all know, but there is no difference in each age group between endometriosis and control. So therefore, the oocytes are not altered. Furthermore, this is the work by Anna Kobo, who looked at the outcome of oocytes obtained for fertility preservation in either cancer, elective, social, or endometriosis. And you see, I want you to concentrate on the diagram at the bottom A. And for this, I enlarged the diagram so you can see better. And you see that the quality of oocytes in endometriosis is not different from that of women who freeze their eggs for social reasons. The oocytes, the message is clear, the oocytes are not altered in endometriosis. We have shown with Dr. Sintuli that actually IVF, the process of IVF and ovarian stimulation does not enhance the symptoms of endometriosis, contrary to what has been thought. So therefore, IVF is very well tolerated in general. Of course, you can have exceptions. This shows the symptoms recorded in blue for women with endometriosis and in green for controls. And if you look at the upper right diagram, you see that all the others are similar, that those symptoms actually decrease at the second visit because that's the time when women are on the pill, and the pill has a beneficial effect on symptoms. But then during the stimulation itself, the symptoms re-increase a little bit, but there is no difference between controls and women with endometriosis. There are symptoms of ovarian stimulation for IVF. It's not different from what you have in women with endometriosis. We also showed that the actual outcome is improved in case of freeze-all and deferred embryo transfer. This is again from our group then at Hôpital Cochin. And this, as you will see, has been reproduced. This is a more recent publication by Dr. Bourdon from Cochin. And if you look at the results, they compared This is in case of endometriosis and adenomyosis. And if you look at the small numbers on there, you see that the actual clinical pregnancy rate is markedly enhanced in the freeze-all group, including the live birth rate, 27% in the fresh versus 53% in the freeze-all. So therefore, freeze-all is the option. And again, this is freeze-all in an estradiol and progesterone cycle when the ovaries are inactive. Now, this is the work by Lorraine Bischoff from the group of Kate Devine, Micah Hill, Alan DeCherney in the Washington, D.C. area. And what they have done, they have looked at implantation rates of women with endometriosis in blue, and the controls were women who had infertility due to male factor or who were undergoing PGTM. And as you see, if you look at the positive ACG rate, if you look at the clinical pregnancy rate, if you look at pregnancy losses and live birth rates, there is no difference between those three groups. Therefore, we know, I believe I give you evidence that A, the oocytes are not altered in endometriosis, and B, the implantation rates, in spite of all the changes that exist, are not altered in freeze-all conditions, that is, in embryos transferred using estradiol and progesterone when the ovaries are suppressed. What happens in conditions of transfers in the natural cycle is anyone's guess. We don't know. Okay? Again, oocyte quality as reflected by equality rate and the data from Anakobo shows that it is not affected by either endometriosis and or asymptomatic adenomyosis. Not talking about huge adenomyosis that makes the uterus looks like a humongous structure. And this is not altered in a estradiol and IM progesterone cycle. Now, in the study, in a workshop that actually followed a meeting in Lugano on July 1st, 2022, we published the excerpts of that meeting in 2023. We analyzed the incidence of repeated implantation failure and found that actually, contrary to what had been said, this incidence is extremely low. It is in the less than 5% when frozen embryos are euploid blastocysts are transferred in estradiol and progesterone cycle. So what happens in fresh transfers and what happens in frozen transfers in natural cycle is anyone's guess. We don't know. So until we have data, our recommendation is clearly, in case of endometriosis, freeze all the embryos and deferred transfer in an estradiol and progesterone cycle. This is the last slide. If you can actually bear with me for another couple of minutes. Actually, I'm still within my time frame. The only proof that endometriosis and asymptomatic adenomyosis do not affect ART outcome is valid only in case of freeze-all and frozen embryo transfers performed in estradiol and progesterone cycles. Now, remember what I said. This is the estradiol and progesterone cycle actually suppress ovarian function. And this is ovarian function. This is probably responsible for alteration. Anything else you do is anyone's guess. We don't know. We don't know. So I wish to hear the arguments of my opponent, but my recommendation is clearly freeze-all and deferred embryo transfer. This is again the group that I work with at Hôpital Fresh, and with particular mention to the role of Dr. Pirtea, with whom I've done most of the work, and Dr. Ayubi, who is the chair of the department. With this, I will say Çok teşekkür. Thank you very much. And I will be ready to answer any questions.
Thank you also. Would you stay with us? Because the second speaker, Professor Recep Papucu, will defend fresh transfer than we discussed later.
So I would like to invite Professor Papucu. He is also one of the leading figures in the field of IVF and endometriosis, and he will defend the side of fresh transfer in patients with endometriosis.
Thank you. Şeyimi alabilir miyim arkadaşlar? Konuşmalarımı, slaytlarımı. Okay. Dear chairmen and colleagues, first of all, I would like to thank the organizing committee, especially to Professor Engin Oral and Ümit İnceboz for inviting me here. And at the beginning of my speech, I want to say in my daily practice, I usually use the frozen embryo transfer, but the topic is given to me is fresh embryo transfer. So I will try to defend this fresh embryo transfer to all. Okay. So bu ilerlemiyor mu? Arkadaşlar bu ilerlemiyor galiba. Bu mu? Okay. My speech plan will be as follows: fresh versus frozen embryo transfer in non-endometriosis women.
Recording in progress.
Disadvantages: frozen embryo transfer, and then why IVF in endometriosis, and why fresh embryo transfer in adenomyosis. So these two miracle heroes realized the first IVF in 1978, and after Louis Brown, maybe more than 30 million babies were born, and they got Nobel Prize, and now, thanks to them, we are doing a lot of things. So, if you look at the fresh embryo transfer program, day 1 or day 2 is the stimulation day. Until the day or 11 and 12, we are continuing the stimulation and egg collection, and then luteal support, and then day 26 is pregnancy test. So, if you look at these two meta-analyses, published in 2018 in Human Reproduction and Fertility Sterility, we will be able to see the cumulative pregnancy and perinatal outcomes in women without endometriosis and adenomyosis between fresh and frozen embryo transfer. So, by using different criteria, these different authors, they demonstrated their results, and then in frozen group, there were some increase in microsomia, hypertensive disease, postpartum bleeding, and then cost was higher, time also was higher in fat cycles. On the other hand, in the fresh embryo transfer group, as you see, live birth rate, cumulative pregnancy rate, antepartum bleeding, NICU, congenital anomaly, and perinatal mortality are almost the same. Although there was a little bit some increase in pregnancy rate, but not significant. But this results were the reality. So, as everybody knows, endometriosis is ectopic implantation of functional tissue, and possible causes to reduce the fertility are, as you see here, adhesion, chronic intraperitoneal inflammation, etc. Adenomyosis also is another headache for us, for all of us. Again, endometrial tissue is located in myometrial tissue. And then at the level of anatomical, cellular, and junctional level, ovum transport, embryo transport, receptivity, and sperm transport are impaired. So, what are we doing in this situation? After performing medical and surgical therapies, we are going to IVF, and we know all procedure. At the end of obtaining the embryo, we are performing frozen and fresh embryo transfer. So, if we look at this literature published in 2006, 7 something, and then they demonstrated us the IVF is better than COH and IUI, especially in advanced stage of endometriosis and adenomyosis, because IVF cycles corrects endocrine and ovulatory dysfunction, abnormal fertilization, and all harmful effects of endometriosis. So, we had published this study in 2006, and we demonstrated that there is no difference between agonist and antagonist using in patients with mild, moderate endometriosis and endometrioma. So, let's come to the result of the endometriosis. This study published Mohammed and Nardo is very, very interesting retrospective, total almost 3,800 fresh embryo transfer, and then almost 3,500 frozen cycles were compared in each group, in all group IVF. In non-endometriosis group, as you see here, there were significant difference in favor of fresh transfers group concerning live birth rate, cumulative pregnancy rate, and miscarriage rate. And in endometriosis group, as you see, same criteria were used, and then all criteria were almost the same. There were no significant difference between fresh and frozen embryo transfer group. So we can say in women with endometriosis, maybe fresh cycles had higher live birth cumulative rate, comparable to live birth rate and cumulative pregnancy rate frozen cycle in the same group. In all group of IVF, as you see again, there were no difference, all parameters. So, I would like to emphasize the importance of the number of egg retrieval. This is very, very important thing. If you look at this literature, these are not endometriosis study. These are high responder groups study. And according to SART data, this is the largest cohort analyzed, it's the retrospective study. Until 15 number egg retrieval, clinical pregnancy, live birth rate, and abortion were live birth and clinical pregnancy were higher in fresh group than frozen. But until 15 number, all criteria are in favor of frozen group. Again, in this Turkish study group, demonstrated until the number of the until the number of the 15 number, same results. This study also is demonstrating is the same result. What I mean, the most important thing, number of oocyte. Until 15 number of oocyte, in women non-endometriosis, in between fresh and frozen transfer group, our criteria are almost the same. What about in endometriosis group? This is retrospective study, and between 2006 and 2017, and 500 freeze all, and then almost 255 fresh group were compared concerning implantation rates, clinical pregnancy, and live birth rates. And now in this study were demonstrated there are no significant difference between neonatal outcomes, biochemical pregnancy rates, multiple pregnancy rates, miscarriage, ectopic, low birth rate, and cumulative birth rate, again until 15 number of oocytes retrieved. So we can say until 15 number of oocytes, cumulative pregnancy rate and low birth rate were higher in fresh embryo transfer than frozen cycles. Abortus rate was lower in fresh group. So in this French study group, 339 women with endometriosis, and 112 out of this group were fresh, and then 227 were frozen. The main result was small gestational ratio, and the secondary analysis, adverse pregnancy outcomes, and perinatal complication. So small gestational age, as we expected, was reduced after FET cycles. We know that anyway. But there was no significant difference between two study groups in terms of mean birth weight and gestational at birth. Again, other pregnancy perinatal complications were not statistically different between two study groups. So if we summarize again the result of this French study, as you see again, the criteria are almost the same between frozen and the fresh group. So in Taiwanese study, again, they showed some similarity by using ovarian reserve, oocyte, number of oocyte, embryo, live birth rates among three groups. So why fresh embryo transfer cycle we should do? Because there are no differences in pregnancy outcomes, no differences in adverse effect, no toxicity for embryo, because belong to high concentration of the cryoprotectants, no need for unnecessary interventions, and cost effectivity and time spent are very high as we expect. So recently, some groups have claimed that they achieved better pregnancy and neonatal results when they applied ultra-long protocol before starting to IVF and before going to embryo transfer, because going to frozen group. But in this retrospective study, were not shown any difference cumulative pregnancy rate and the live birth rates. Also in prospective randomized control study, and then the results were the same. And this study also shown the same results. Additionally, ESHRE is not giving any recommendation for transfer in women with endometriosis and adenomyosis group. So finally, we can conclude that if the number of oocytes is low, patients whose cycle is not very long, if the PGD test is not required, fresh embryo transfer is more suitable. Because we don't have sufficient data, level 1 evidence and guideline recommendations, we should not transfer frozen embryo unnecessary. Thank you for your interest and participation.
Thank you very much, Professor Papucu. So, Professor Ziegler, can you hear us? Can you hear us, Professor Ziegler? Can you, I think it's muted. Can you open it?
Okay.
Okay, so we also would like to thank you. Okay, we also would like to thank you for keeping in the line. So the topic is open for the discussion. Is there any comment or question? So maybe in the beginning we can ask you, Professor Ziegler, do you want to make any comment for the second speaker? Or for the second?
Yes, I want to thank the second speaker for presenting his data and supporting the fresh transfer. I think one should not confuse the different issues. One is the success rate of IVF in endometriosis. For a long time, it was said that ART had a lower success rate in endometriosis. Now, we know that this is not the case. The recent data support two things. First of all, for two reasons. So one, I did not emphasize that, is also to avoid the cyst formation. When you have endometriomas, it makes sense to use only agonist trigger because it avoids creating a new cyst. And all the data that actually show, without a doubt, the absence of a difference in implantation rate were conducted in estradiol and progesterone cycles. As I said, the rest we don't really know. We don't have recent data on that. And this includes endometriosis and asymptomatic adenomyosis. Okay. So we go for that. I mean, I maintain I enjoyed the presentation from my opponent, my distinguished opponent, but I maintain my position.
Okay.
Until we know more. And the issue of preeclampsia is an important one. The increase is small. The increase needs to be determined with more precision as to whether it is linked to the actual culture of the embryo to the blastocyst stage, to the freezing process, and or to the preparation with an HRT cycle. We don't know yet very well, but the increase is minimal, and it needs to be evaluated. Maybe transfer in a natural cycle or modified natural cycle is okay, but at this time, no one has studied that in endometriosis and adenomyosis.
Okay. Dr. Ziegler, can I ask you your comment? After having good, very nice blastocyst stage embryo, if you are planning to go to frozen transfer, are you performing ultra-long protocol to suppress the harmful effect of endometrium at the level for receptivity, for increasing of the receptivity of the endometrium?
You're talking about suppressing with an agonist or something like that?
Yes, with agonist, ultra-long protocol before going to frozen embryo transfer.
First of all, years before, there was a work by Dr. Schoolcraft's team indicating that an ultra-long protocol with an agonist for 6 months was actually providing better results. This is not believed to be the case anymore, and actually the X-ray data don't support that anymore. I think that instead of that, we have the equivalence, and we have excellent results with the antagonist protocol and Frisol.
Okay.
Is there any question? Yes, Dr. Roy.
Dr. Ziegler, this is Engin Erol. Thank you for accepting our invitation. Thank you so much for your time, for your effort. And the first question is ovarian reserve is important to decide the fresh or frozen transfer endometriosis patients with or without adenomyosis. This is the first one. Dr. Papucci, Dr. Ziegler.
Well, anyway, we are collecting less eggs than we expect in endometriosis and adenomyosis group.
Would you prefer fresh or frozen transfer, either diminished ovarian reserve or patients with the high responder? I mean the endometriosis or with or without adenomyosis.
Of course, in high responder group, frozen embryo transfer is much more effective because in your hand, a lot of healthy, you have a lot of embryo in your hand. In the future, cumulatively, your pregnancy rate will increase. Right, Dr. Ziegler?
Did you hear us, Dr. Ziegler?
Do you hear, Dr. Ziegler? Did you hear the questions?
Could you answer the question again?
Yes. For the decide of the fresh or frozen embryo transfer for the endometriosis patients with or without adenomyosis, ovarian reserve is important or not to decide which transfer style?
I'm sorry, I could not hear very well.
So maybe I can speak in here.
Yeah.
So Professor Oral is asking, I mean, when you decide to make fresh or frozen embryo transfer cycle, is ovarian reserve is one of the factors that you can consider? I mean, for example, if she is suffering from low ovarian reserve, maybe you can select a fresh embryo transfer, but if she has still high ovarian response, then maybe you can prefer frozen embryo transfer cycles.
Well, all rules in medicine have exceptions. No. So if you have a person whose response is extremely weak, we may do a fresh transfer. But the rule is for anyone who has more than 4 and 5 oocytes, we go for Frisol.
And the second one, for the fresh transfer, would you prefer the cleavage stage transfer or insist of day 5 transfer for the endometriosis patient?
So the second question is the day of the embryo transfer, the sites on your side to make fresh or frozen embryo transfer?
I mean, for the fresh transfer.
Yeah.
Would you prefer the day 3 or just the day 5 transfer in endometriosis patient if you decide the fresh one to you and to Dr. Papucci? Thank you.
The question about day 3 or day 5, is that the question?
Yes, for the fresh transfer.
For the fresh transfer, if you are planning to make a fresh embryo transfer.
We do, for our fresh transfers in all our patients, we do about 35% of fresh transfers and all the rest is frozen. But for the fresh transfers, we do, in general, day 5 transfers for everybody, endometriosis and that.
Any questions? Any other questions? So can I ask one, Dr. Ziegler? So yeah. which protocol do you prefer in patients with endometriosis, only with endometriosis, or patients with both endometriosis or adenomyosis? For example, letrozole-induced ovarian stimulation protocols might be one of the choices that can be employed in those kind of women.
Well, the story about the letrozole is a story that's emerging and new and very interesting. We don't have personal data. We actually have a paper in preparation, and the person who has most work on using letrozole in the ovarian stimulation outside of cancer is Dr. Nick McClellan. Actually, we are preparing a series of articles on that. I personally don't have any information on letrozole. Possibly it is better. I do not know. This is something we have to follow, and we have going to have a series of views and reviews in fertility stability, and one article will be by Nick McClellan looking at the effect of letrozole. It's a very good question.
Thank you very much. Any other questions? Okay, thank you very much to contribute to
Teşekkür.
Teşekkür.
Okay, bye-bye.
Thank you, bye-bye. Bye. We finished this session. Now for the closing remarks, I invite Engin. Yes, please.
Thank you. So everything has an end, and this is the end of this meeting. We have spent 2 busy days, and it was wonderful, at least for me. We have as 4 chairmen, Andrew, Krina, Engin, and myself. And obviously, most of the work was done by these 2, actually 3. Where is he? He has gone. Right, okay. By these young colleagues. First, I'd like to applaud them. Would you please join me? And I do hope that we did a bridge between bench and the bedside. And I do hope that we can collaborate more and more. And I believe that our collaboration has been strengthened, and also our friendship. And thank you very much for being here until now. Thank you very much, and hope to see you in another meeting. Thank you.